good afternoon, everyone. A very warm welcome to all the participating speakers, representatives from various ministries of health, distinguished members of various fertility and embryology societies, healthcare professionals, and our dear Merck Foundation alumni who have joined us online for this amazing fertility care and sexual and reproductive health session under the auspices of Merck Foundation More Than a Mother movement at this 13th edition of Merck Foundation Africa Asia Luminary 2026. My name is Dr. Shadab. I'm a scientific and medical manager with Merck Foundation. I'm also the scientific lead for this fertility session today. Based on the guidance and recommendations received from the Ministry of Health and Family Welfare of the Republic of India, and following careful consideration of the evolving public health situation and the rising concerns surrounding the recent Ebola virus outbreak in various parts of Africa, Merck Foundation decided to prioritize the health and safety of all its stakeholders, speakers, and alumni, and conduct this 13th edition of Merck Foundation Africa Asia Luminary virtually. Merck Foundation continuously strives to improve access to quality and equitable healthcare solutions in underserved communities by strengthening the local capacities and enhancing the clinical management processes through its various scholarship programs offered under the Merck Foundation More Than a Mother movement. Merck Foundation offers hands-on training programs in fertility and embryology at its partner institutions. Besides, it also offers scholarships in 44 critical and underserved medical specialties, including one-year postgraduate diplomas and two-year MSc degrees in sexual and reproductive medicine, women's health, family health, biotechnology of human-assisted reproduction, clinical psychiatry, urology, and many more. I would now request my colleague, Dr. Parthasarthi, Scientific and Medical Manager at Merck Foundation and co-moderator for this session, to kindly begin the session by introducing our first speaker for the day.
Thank you so much for the introduction and the opportunity, Dr. Shada. Good morning and good afternoon, everyone. It is my absolute pleasure to introduce our first speaker, Professor Dr. Oladapo Hashiru, OFR. He is the President of African Reproductive Care Society, President of the Academy of Medicine Specialists of Nigeria, and Secretary General of International Federation of Fertility Societies, Nigeria. Over to you, Dr. Professor.
Good morning. It's a pleasure for me to be here. I'll be talking today on the assessing the influence of environmental and dietary factors on sperm quality in men and IVF outcomes. I'm Professor Oladapo Hashiru, and I do not have any conflict of interest. I'll be speaking on introduction, male infertility, environmental toxins, endocrine disrupting chemicals and their effect on reproductive health, strategies for mitigating this, conclusion, and call to action. As I said, there are no conflicts of interest by me. And let me now look at the issue, what are environmental toxins? Environmental chemicals or toxins are compounds or elements in the air, in water, food that we eat, soil, dust, or other environmental media such as consumer products. And these are also have been found in urine, blood, serum, breast milk, and meconium. And they contain more than 300 chemicals as reported by Center for Disease Control. In terms of background, historically, the oocyte quality, the uterine environment, and the male sperm have been associated with IVF failure. Evidence emerging evidence show that the male gamete contributes far more than just the DNA. The central, the activation signal, and epigenetic programming have been known to be associated with IVF failures. Now look at the sperm quality in terms of beyond the standard of semen analysis. Now with the advanced technology and microscopy, we're able to see other aspects in the sperm quality. On the left side of the screen, that is a satisfactory for functional sperm features. And on the right side, it is unsatisfactory. Look at the acrosome reaction, the way it looks. the plasma membrane are intact, the DNA integrity, very low reactive oxygen species, and then mitochondrial quality is very active, and sperm motility is high on this side, normal sperm. Whereas on this side, you could see the acrosome membrane is damaged, the plasma membrane is damaged, DNA fragmentations are present, and very high oxygen, reactive oxygen species in the quantity. Mitochondrial membrane is low, and these are the abnormal things we see in today's activity. So the key points to take home is that routine sperm analysis does not explain 30 to 40% of male factor infertility. Critical metrics for IVF outcome include DNA fragmentation index. More than 30% reduces blastocyst formation. And oxidative stress measured by the reactive oxygen species reduces total sperm capacitation. And epigenetic factors also are necessary for coding the RNA. Environmental and dietary factors predominantly act through these hidden pathways which are not known up to now. And you could see that oxidative stress as well as male infertility, they include the following diagnostic approaches. Here, you could see that the lipids are damaged by endogenous sources like varicocele, immature spermatozoa, and leukocytes. They act on the cells, and then also exogenous by lifestyle like eating, hamburgers, smoking, alcohol, and other toxins. They all have effect on the sperm integrity. There are also clinical factors that are dose dependent, and they are often not linear. No dose may have serious effect. They include things like canned food, vinyl flooring, tubings, and so on and so forth. You can also see that the route of exposures of toxicants are plenty. These are starting from fumigation by pesticides, phthalates, cosmetics, bisphenol in food containers, in thin foods and plastic food, in retardants, in the chemicals, in smoking, car pollution, and many others are shown here in this illustration. The phthalates can be ingested, they can be inhaled, or they can be put on the skin, and they affect the mechanisms for the sperm, and you can see them in the urine, and they create oxidative stress that reproductive outcomes include sperm concentration decrease, decreased sperm motility, abnormal sperm morphology, and of course, low fertilization potential, and IVF failure comes into action. Phthalates are plasticides found in personal care products such as, and these ones have been shown to affect the testes, especially the Sertoli cells and the Leydig cells. They induce testicular damage, and they are able to create a low fertility rate in patients. These have been shown as recent as 2020 and 2025. Phthalates are volatile compounds, parabenphenol, in the environment, and these chemicals they have been shown to present in menstrual period, and they affect so many things like this genesis of this genesis syndrome of the testes and several other issues. Bisphenol are in plastic containers. They cause low sperm concentration, high risk of low sperm concentration, and they also affect human oocytes. Pesticides such as organophosphates have been shown in agricultural workers to show high percentage, about 50% of sperm aneuploidy. And this was published by Giuliani in 2022. And they are inversely associated with IVF outcome as well. Organophosphates are a class of neurotoxic chemicals they use in warfare. However, they have been shown to decrease success in IVF and have developmental problems in the offspring of babies so born. The next are the heavy metals and air pollution. We have lead and cadmium. They accumulate in seminal fluid and they inhibit protein substitution by DNA packaging. Therefore, they increase DNA fragmentation by as high as 5%. Mercury also has been known to reduce sperm mitochondrial membrane and potential, and that also has problem in fertility outcome in IVF. Next is the exposure to what we call particulate matter in the air. Any PM in air pollution of 2.5 and above and natural oxide exposure in 90 days prior to semen collection can cause a decrease in sperm motility by 5 to 10% and increase chromatin decondensation process. And there's a prospective study showing up in China since 2022 that shows that people living within 500 meters of major high road have 15% low birth rate per IVF cycle. And you could see that this decreased sperm motility, increased condensation, and even in households that are very close to high road, major road, these are the things that occur within the house environment. Other lifestyle and occupational factors include smoking, which decreases seminal antioxidant enzyme, GPX and salt, and heavy alcohol, decreased testosterone and altered seminal zinc. These are modifiable within 3 months of washout, but they have those effects. So these exposures can come from the climate change, air pollution, water pollution, mining pollution, deforestation, and in the environment, such as personal products that we're exposed to, device exposure, pesticides, and other endocrine disruptor chemicals. The climate change, the science basics is that ozone, carbon monoxide, sulfur oxide, and particulate matter less than 2.5% are injected into the environment, and the 7 warmest years have been recorded in the last 7 years since 2015. Air pollution, heat combined to create synergistic risk, and climate change and environmental are interactive in some of their effects. And this has been reported by WHO and other areas, and we need to make sure that we do research to translate this development through FIGO and other concerns and establish advocacy to let people understand the risk of this climate change and toxic environmental exposures by continuous education and training. Association between air pollution and heat has been shown. They analyzed about 3 million births and showed that there was significant association of air exposure pollutant and heat with birth outcome. Same with preterm birth with particulate matter. So there is increased risk to pregnancy with these exposures. Also, they've shown this publication to show this that occur when there's approximately 3% of PTB in USA corresponding to about 15 to 16 million, and it could be attributed to particulate of matter. And preterm birth cost estimate in the US about 15 billion, and 760 million was spent on medical care. Air pollution and spontaneous fertility. We've seen studies that air pollution can cause self-reported infertility in people living in major high roads, and living live birth in per 1,000 pregnancy is low with people living in those areas. So it was reported also in Denmark. Now, should we be concerned? Yes, we should be concerned because we should be concerned about this because the publications by several studies has shown that these substances can cause testicular cancer, breast cancer, diabetes, autism, hypospadia, low sperm count, and other problems. And of course, when the committee of opinion by the American has shown that these endocrine disorder chemicals have implication on human health because they can cause gestational diabetes, reduce sperm quality, polycystic ovarian disease, and so many other problems, as also as phthalates and pesticides reduce sperm quality and motility. This is the pathway through this impairment can occur, this dysfunctional reproductive cells, molecular pathway, and altered hormone pathways, as reported by my PhD student, Fisher. So these chemicals on production, difficulty in conception, miscarriage, abnormalities in babies, and pesticides can affect 3 generations: the mother, the pregnant baby, and then the baby to grow by that pregnancy. And so this is the need for us to be very careful about the way it goes. The mother is affected, the baby, and then the reproductive cells of the 3rd generation is also affected. Now, as we go on this, we also see that there are a lot of work that has been done to show that testicular toxicity in Nigerian bony light crude oil, which we reported. So this is environmental toxins on the testes from crude oil. For those who live in this environment, they affect sperm motility and morphology in experimental animals. Furthermore, Frank Zeppermeyer created the so-called Meyer therapy, which employs a battery of things which we have now shown that these things, they can be removed from the body when you are trying to have fertility, with a significant result in terms of even the body weight and the abdominal conference, and also improved yield in the IVF outcome when patients go through this process. And that you can see in the next slide, where we manage environmental exposure in clinical practice. And we showed that in the 2 groups that were formed, there was increased ovarian yield, increased oocyte, increased fertilization rate, increased pregnancy rate, and it was very useful. And since then, we've been talking about preconception cleansing before fertilization. We've also shown detoxing as a potential intervention for improving IVF outcome in various patients. And the results are very encouraging that this is the ratio. And in general, we do say that if you have ART and environmental toxin, you take the patient history. If they've been exposed to occupational toxins, you better take them through bioenergetic testing and detoxification, preconception crisis. If it's unexplained fertility, the same thing. And then you can now, before they go through their fertility treatment. These are the recommendations they now believe can be done. So you recommend health choices for patients. You give lecture to your colleagues, and also you reduce carbon footprint. There is elimination for environmental toxins. You establish climate change committee and toxic exposure committee in your societies, and you advocate for safe chemicals and various standards in your countries. Lastly, the solution has to be a together work. The health professionals, educators, community group, media advocacy, legislators, government agencies, and researchers, they must work, interact to help to reduce this effect on male infertility as well as on the female infertility. So for the IVF clinic, take male environmental history. Make sure you measure the reactive oxygen species and the DNA fragmentation if they are with unexplained IVF. Dietary intervention includes eliminating sugary drinks, processed meat, trans fatty acids, increased leafy green, increased nuts, and omega-3 important. Supplements such as CoQ10, zinc, vitamin C, and selenium have been helped to remove these components from the body. And you can switch from using to glass instead of plastic containers and use HEPA filter in your environment and avoid thermal stress like laptop and wear loose underwear instead of the tight ones. These are things that have been shown to have very good effect. In conclusion, I may bold to say that our environment consists of large number of endocrine disrupting toxins. They are in the air, they are in the food, and they are in the soil and other products that we put on our body. These heavy endocrine disrupting chemicals like heavy metal, pesticide, have significant reproductive consequences in the male and the female. And we need to minimize their effects by exposure, by preventive measures, and male detoxification offers the best preventive measure that minimizes this effect with positive implications for fertility. These are my references, and I end this talk by the word of Beethoven that says, "I recognize no superiority in mankind other than goodness." Thank you for listening.
We would definitely like Professor Ashiru to comment on his presentation and the session until then, please. Over to you, Professor Ashiru.
Very good. I'm happy again to be at this event, which Merck Foundation have been doing to expand human capital development and resources and knowledge in the field of reproductive health in Africa. The presentation specifically is important because there is clear and present danger to fertility from the environment. And what we need to do as fertility providers is that there are some basic tools that, as a matter of routine, we need to start adding to patients, male and female, going through infertility. Number one is selenium capsule, 200 milligrams, which has been known scientifically to help to chelate heavy metals from the body. And the second one is omega-3, which has been known to help in the quality of the sperm and the egg by improving the mitochondrial DNA as well as improving the reactive, the endoplasmic reticulum of the gametes. And the third one is coenzyme Q10, which is also important in DNA mitochondrial formation. Last is vitamin D3. These four components are essential for us to routinely give to anybody going through conception, just as we routinely give folic acid to prevent abnormalities in the female. We have made significant success in removing these environmental toxins, which WHO now recognizes as a major hindrance to infertility. Is an obstacle that we need to be aware of. And the sad part is that many people are carrying these toxins not known or unaware of the fact that they have it, male and female. I've had patients who carry antimony in their body because they drive barefooted for years, and this prevents a conception. Thank you.
I'd like to introduce our next speaker, Dr. Edam Hiadzi, obstetrician, gynecologist, fertility specialist, founding CEO of Lister Hospital and Fertility Center, Ghana, and the immediate past president of the Fertility Society of Ghana. His presentation topic today is the evaluation and management of male factor infertility in resource-limited settings, practical diagnostic pathways, role of semen analysis, hormonal evaluations, and genetic testing. Dr. Edam, the stage is yours, sir.
Thank you very much, Merck Foundation, for this opportunity again. I always admire the efforts you've been making to bridge the gap between fertility care and awareness between the lower income and the higher income group. Within the few years that you've been promoting this, a lot has happened in Africa by way of countries who never had an IVF unit, starting them, countries that didn't have fertility societies, starting them, Ghana being one of those, just from the enthusiasm you've put into this mission. We would continue to support as much as we can. So just a brief overview. We'll start with a brief introduction, then evaluation of male factor infertility divided into a detailed reproductive history, comprehensive physical examination, then semen analysis, which is a cornerstone of male evaluation. And then we move on to the management approach in resource-limited settings, and then have a short conclusion. Yes, a male is considered infertile if he's had regular and protected intercourse with his partner for a year without a pregnancy, just like in the female. Recent global data shows that the male factor accounts for nearly 50% of cases of infertility. And as noted, there's gradual decline in semen concentration over the last half a century. The etiology of infertility may fall broadly under biological, lifestyle, and environmental factors, but infections remain a major factor of infertility in resource-limited settings. We believe that focusing evaluation and management through public and community health education and emphasizing preventive care should be recommended. Training of general physicians and community health personnel on basic fertility workup at the primary health care setting will be cost-effective, as we are all aware that early diagnosis and treatment will prevent delays and complications that will end up requiring more expensive assisted reproductive technologies. So, evaluating of male factor infertility. Detailed reproductive history and thorough physical clinical examination should be at the same level as in resource-rich settings, because this will not add any extra cost of taking a good history and good examination. The hormonal and genetic checks may become necessary at a later time. And before we understand the process, what happens in a fertile man? First, the pituitary hormones released, gonadotrophic is released from the hypothalamus to the anterior pituitary, which then provides LH and FSH, luteinizing and follicle-stimulating hormones, which then affect the Sertoli cells and for spermatogenesis, and then Leydig cells for testosterone production. Now the testosterone and inhibin from the Sertoli cells bring a negative feedback onto the anterior pituitary and the hypothalamus to then control these processes. So what about evaluation? You start first from childhood and adolescent history about cryptorchidism, mumps, orchitis or epididymitis, whether there's been any testicular trauma or head injury with loss of consciousness, which could affect the blood supply from the hypothalamus to the pituitary and beyond. Then pubertal delays in the males. You then ask about lifestyle factors like smoking and alcohol, recreational drug use, cannabis or marijuana, cocaine, heroin, and methamphetamines. Then the history about excessive heat exposure. People feel it's controversial, the use of hot tubs, saunas, and steam rooms. But we know that high temperatures will affect meiosis, leading to oligospermia, or mitochondrial damage, leading to motility issues, or protein damage, which affect morphology or DNA fragmentation by the release of ROS. Then about the reproductive history. It's important to ask about the age of the partner, the duration of time trying to conceive, then the contraceptive method and the duration of use, because sometimes they forget about these things, and a problem in the partner may be what is leading to the infertility. So the partner history is very important here. Previous pregnancy or miscarriage with either the current or the previous partner will let us know whether they've been fertile before or not. Then whether the female partner has been evaluated at all, is important. Next slide. Then the sexual history itself, the frequency, the timing, whether they have any erectile or ejaculating issues. Then the use of lubricants. It shouldn't be trivialized. One of those commonly used is KY jelly, but it has high osmolality, practically shrinking the sperm and paralyzing them. Some people use saliva, but this contains enzymes and harmful bacteria, or others, olive oil, coconut oil, or petroleum jelly. These just form a thick, heavy physical barrier and alter the motility of the sperms. Then current medical history, history of diabetes, autoimmune disease, cirrhosis, or hypertension, which will all either directly through their inflammatory conditions or the medications used also affect the fertility of the man. Then sexually transmitted diseases, tuberculosis, viral infections, genital, other infections, which can, through inflammatory processes, cause tubal blockage or other affections of the genitals. There's important is cystic fibrosis. If there's a history of that, you must look out for presence or absence of the vast difference. We then come to the medications. Very, very important in your male factor infertility. Anabolic steroid use. This affects the hypopituitary gonadal axis, causing severe or azoospermia, reduced motility, abnormal morphology, or even testicular atrophy in these bodybuilders. The use of testosterone supplements just acts as a male contraception. What about antidepressants? Selective serotonin reuptake inhibitors like sertraline and paroxetine increase sperm DNA fragmentation. Tricyclic antidepressants, nortriptyline and imipramine, cause erectile dysfunction, and through a rise in prolactin levels, also affect the HPG axis, lowering LH and FSH, thus decreasing spermatogenesis. Then when you go to the antihypertensives, commonly used are the calcium channel blockers, amlodipine, nifedipine. These reduce motility and cause impaired capacitation. Beta blockers, atenolol, metoprolol, reduce motility and also cause erectile dysfunction. The thiazide diuretics reduce sperm volume and cause erectile dysfunction. And then other diuretics like spironolactone act as anti-androgens, reducing testosterone production. Then when you come to hair loss or prostate medication, finasteride and dutasteride, tamsulosin, they all reduce sperm volume, block alpha adrenergic receptors, and cause either retrograde or anejaculation. Chronic pain medication that we normally use, morphine, tramadol, fentanyl, they all affect the HPG axis. GIT and autoimmune medications, sulfasalazine, which is very good for these, cause a direct toxic effect on sperm production. Then when you move to the anti-epileptic drugs, valproates, levetiracetam, carbamazepine, phenytoin, all lead to overproduction of the sex hormone-binding globulin, which then binds testosterone and affects your sperm production. You then move to surgical history, ask about previous hernia or scrotal surgery. Maybe there's been orchidectomy or on account of testicular cancer or from torsion. You need to know that. Whether there's been prostatectomy, bariatric surgery, or bladder neck surgery, all these affect the nerves that control sperm transport and may affect fertility. Then gonadotoxic exposure, previous chemo or radiotherapy is important. Then exposure to environmental toxins. Professor Shiri mentioned some of this in his lecture. Lead, for instance, disrupts the HPG axis, affecting testosterone production. Mercury causes sperm apoptosis. Pesticides through the organophosphates endocrine disruptors and block androgen receptors, leading to sperm DNA fragmentation as well. Then for smokers, the cadmium from tobacco smoke or even electronic waste and contaminated fertilizers cause oligospermia and decrease motility. So what about physical examination? You first focus on the general physique, check the BMI, whether there's gynecomastia or poor virilization, check the genitals for any scars in the inguinal or scrotal areas. Then with the testes, you check the volume, consistency, and the tenderness. The penis, is there hypospadias, epispadias, phimosis, or is there a curvature which may affect the ability to have proper intercourse? Then look for tenderness or cysts in the epididymis, and then the vas deferens, is it present or not? Then the spermatic cord or the scrotum for varicocele, hydrocele, or presence of cysts. Yes, what about the investigations? Semen analysis is the cornerstone of male fertility investigation. And in resource-limited settings, you just use the basic volume, concentration, motility, and morphology within the context of the WHO 2021 abridged version, where volume should be between 1.5 to 5, concentration should be more than or equal to 16 million, motility 40 or 42% and beyond, with morphology at least more than 4%. If all the parameters of the first analysis are normal, a repeat is not required. Now, it's important to know that sperm count fluctuates. Therefore, if you get a low sperm count, the second sample should be done after about 2 weeks with a 3 days abstinence. If 2 or more of those analyses are abnormal, then you need to wait for 3 months, which is the normal duration of spermatogenesis, before you do a further repeat. Yes, investigations continued. Hormonal evaluation is only reserved for severe cases of oligoasteroteratospermia or whether it's exospermia. And this brings in place the hypothalamo-pituitary testicular axis, where you would check FSH, LH, testosterone, and prolactin as well to assess their function. And that will give you an indication of where a possible fault could be, or whether there's spermatogenesis going on or not. Advanced investigations, as is mentioned, are only required in severe oligospermia or exospermia. With genetic testing, you may be doing karyotyping to rule out Klinefelter's, XXY, or Kallmann syndrome, which will have anosmia as well and delayed puberty. Then Y chromosome microdeletion, which can be transmittable. That is important as well at those stages, but these may not be available in resource-limited settings. But it will be important that you refer to centers that can do this. Scrotal ultrasound for detection of varicocele or testicular tumors. Transrectal ultrasound may be required to evaluate blockages in the seminal vesicles or ejaculatory ducts. Then sperm function tests may be required, capacitation, a chromosomal reaction, or sperm DNA fragmentation tests. What will be the recommended strategy of approach on the management of male infertility in resource-limited settings? It's believed that management should start with an emphasis on prevention. And at this point, I'll quote what our WHO head, Dr. Ghebreyesus, mentioned in his foreword to the 2025 WHO guidelines for the prevention, diagnosis, and treatment of infertility. He said, fertility care, which includes prevention, diagnosis, and treatment of infertility, should be accessible to all who need it without stigma or discrimination, which means even resource-limited settings should have this basic care. It's a fundamental human right. This is addressed in the chart up here, which is central to human rights and global health aspirations. From gender equality, both men and women should be investigated. Universal health coverage. This fertility treatment should be accessible to all. Equitable access. It's mentioned here, financial protection. The budgets of any country should consider some fertility care for even the low income. Primary health care, this should be available at primary healthcare settings. Right to enjoy benefits of scientific progress, yes, which must be introduced as it evolves, and then the right to health. Everyone has a right to enjoy the highest attainable standard of physical, mental, and social well-being. I then put 2 slides here on the Ghana approach. What did we do in Ghana? Well, first we thought about capacity building of a task force. So we started by identifying a few fertility specialists within the country to steer the establishment of a national fertility society. Then this group focused on fertility education of the OBGY, that's the obstetrician gynecologists, general practitioners, and nurses on fertility issues through quarterly continuing professional education and annual conferences. These people serve now as the front line for public education on radio, TV, schools, churches, and other public fora to increase awareness on infertility, with emphasis on the fact that this could be the fault of the man or the woman in equal measure. That's 50-50 accountability. We then engage the media to help with dissemination of this knowledge, to spread it as far as possible for the common man to understand what fertility is and the requirements. And here again, Merck Foundation has been very key in pushing for this dissemination through the media, health, fashion groups, and all that. Then we negotiate with our National Health Insurance Authority to cover at least the basic fertility tests so that the ordinary person in the district hospital or even the CHIPS compound should be able to have some basic fertility work covered by the National Health, including maybe initial control stimulation with clomiphene or letrozole under the National Health Insurance Scheme. This approach allows most cases at the district level to be diagnosed and managed early, and then the more complicated ones referred to regional and bigger hospitals. I then looked at Continental Fertility Societal recommendations. ESRE, which is the European Society for Human Reproductive and Embryology, advocates for an individualized, low-tech, and cost-effective approach, prioritizing basic standard clinical and lab evaluations to prevent over-investigations, as you can see in the initial part of the presentation. ASRM thinks mandatory simultaneous assessment of both male and female partners should be from the onset, and no routine ultrasound, endocrine, or genetic testing, except for severe oligo and oligospermia. FIGO equally advocates for concurrent evaluation of both partners and the use of the FIGO fertility passports. We found health education to be key in the low resource settings. The aim to provide knowledge about infertility using low-cost strategies like information in digital or paper format infographics in schools, primary health care centers, reproductive health like family planning clinics, and then churches and mosques, etc., just disseminates the information about fertility and infertility and its causes. You adapt this information to the local context, reiterating the risk of sexually transmitted infections. Safe sex must be practiced. Lifestyle modifications like weight management and physical activity. Then age-related fertility decline. It's important to let people know that the eggs don't wait forever. Similarly, even with the sperms. Then timely medical consultation. People should not self-medicate. Otherwise, they will run into more complications. Lifestyle changes, important, like healthy weight, looking at BMI, eating more fruits and vegetables, regular physical exercise, stress management by social groups or yoga or meditations. Then stop nicotine, alcohol, and recreational drugs. Avoid lubricants during intercourse, which may contain spermicidals. In fact, the WHO recommends that when you can use just between 30 seconds and 3 minutes per encounter to talk about this lifestyle modification, it goes a long way to improve the dissemination and also healthy practices within the community. Yes, this just goes to tell about what foods to avoid and which to eat more of. Then with the management, when it comes to the medication, you realize I mentioned several medications which have very detrimental effects on male fertility in the evaluation period of medical treatment. You can find alternatives to such drugs. Instead of using the tricyclic antidepressants, you can use the serotonin norepinephrine reuptake inhibitors like venlafaxine or duloxetine. This preserves sperm integrity and provides stable semen parameters and hormonal stability. Instead of, you may also use norepinephrine dopamine reuptake inhibitors like bupropion, which also do not affect sperm quality. For antihypertensives, it's better to replace the calcium channel blockers with angiotensin converting enzyme inhibitors. This lisinoprene, enalaprine, they don't affect the sperm function. Similarly, the angiotensin 2 receptor blockers like losartan and valsartan are safer for the men. Replace the tamsulosin, which may be affecting prostate medication with minoxidil or alfuzosin. Chronic pain medication, instead of using those opiates, switch to gabapentinoids and acetaminophen. They do better. Instead of there's the sulfaxine for the autoimmune medications, you replace them with mesalazine or basalazide. The anti-TNF and biologics are a little more expensive, so we can leave those out, but they are good alternatives. And then for the anti-epileptics, lamotrigine and oxcarbamazepine do better than the other ones. So there are drugs that can be substituted with less effect on sperm function. When it comes to surgery, varicocelectomy should be done only if sperm parameters are outside the reference age. So even if you find varicocele in a man who has normal sperm, it's not necessary to be doing varicocelectomy. Reversal of vasectomy is an option. If it's successful, this may lead to spontaneous pregnancies. So you can repeat the semen analysis 4 weeks later to check if things are back to normal. If the parameters are good and the female has regular cycles, then expectant management is recommended with lifestyle modification and timely intercourse at ovulation. If this fails, then you use clomiphene citrate or letrozole stimulated cycles with ovulation trigger, and then you may follow this with intrauterine insemination. When all this fails, well, then you may have to send to higher centers for these various assisted reproductive techniques, which is outside this topic. So in conclusion, infertility is a disease of the male reproductive system and can be primary or secondary. It does not differ significantly between high income or middle income regions, indicating that it is a global public health issue. However, the distribution of the underlying risks of infection, such as sexually transmitted infections, unsafe abortions, and postpartum infections, which is much more in the resource-limited settings, may lead to differences in the patterns of primary or secondary infertility. Thus, improving the health education and fertility awareness and lifestyle modifications will go a long way at reducing the burden of infertility in resource-limited settings. These are my references. Thank you very much for the opportunity to share again on this platform. Thank you very much.
Thank you, Dr. Ida. I would like to call upon our next speaker, Dr. Praveen Prabha, President, Malaysian Society of Assisted Reproductive Technology, Malaysia. He will be presenting the topic Unexplained Infertility, Advances in Diagnosis and Individualized Management Strategies.
Good afternoon, everyone. This is Dr. Praveen Prabha. I'm the president of the Malaysian Society for Assisted Reproductive Technology, or MSAT. First of all, I'd like to hand over my thanks to the Merck Foundation for inviting me to be part of this plenary. Obviously, we had a much bigger function in mind with attendees from all over Africa and Asia, but that was put to bed because of an outbreak of the virus, as it were. But I think it will still be a brilliant plenary session. And again, I'd like to record my thanks to the good folks of the Merck Foundation for being able to do it. My topic today will be on unexplained infertility, advances in diagnosis and individualized management strategies. Obviously, I'm going to focus more on the developing countries, like in Africa and Asia, while talking about this. So what we're going to do is, after an introduction into unexplained infertility, I'm going to talk about the advances in diagnosis and how we arrive at what is essentially a diagnosis of exclusion. I'm going to talk about patient values and constraints, individualized management strategies, and then probably a summary of all that we've gone through. First of all, an introduction. What is unexplained infertility? It's infertility in couples that actually have no abnormalities detected during screening, a diagnosis of exclusion, as it says on the bottom of the slide. Now, this is very important to note because you can't diagnose unexplained infertility on the day the couple walks into your office. It obviously requires a screening, and then we arrive at a diagnosis. So couples like this have an apparently normal ovarian function, normal fallopian tubes, uterus, cervix, pelvis. Age we take as less than 40 years old, normal testicular function, normal ejaculate, normal semen analysis, and with adequate coital frequency, which we normally put at 12 months of regular unprotected intercourse. This changes, of course, if the couple is more aged, over the age of 40, we'd probably say 3 to 6 months. So if you look at the further breakdown of this particular data, but recent, more in-depth studies and data actually show that slightly different. Now we come to part 2. Now this is quite important, assessment of tubal disease. Your unexplained, your combined causes, which in Africa and Asia actually is about the average, Africa slightly higher, and the unexplained infertility bit, you can see Africa is a lot lower than the average world mean, whereas Asia is just about there. Okay, on to the next slide. So this is again a pictorial representation. You can see that when you screen a woman for the first time, up to 33.5% of them will have no discernible cause as to why they're suffering from infertility. It's even higher in the male population, where almost 46% of all men actually have no discernible cause for infertility. Next. So that brings me to advances in diagnosis. So today we're going to talk about how we're going to diagnose and come to our diagnosis of exclusion of unexplained infertility. So let's start with the women. This is a WHO algorithm that was published last year. This is the women's part of the algorithm. We'll come to the male part a little bit later in the slides. I know it's a very busy slide. I don't need you to look at everything on the slide, but if you look at that bottom line there, you can see that one whole big batch is given up to unexplained infertility, and there are 4 other main causes, which are tubal blockage or disease, uterine cavity anomalies, ovulation disorders, and reduced ovarian reserve. So once you've ruled out these 4 particular things following the algorithm above, you arrive at unexplained infertility. Next. So how do we assess the female? We start with confirmation of ovulation. Now, again, I'd like to point out that in some cases here in developing countries, you're dealing with centers that don't have access to a lot of very modern or hi-fi equipment, and therefore history taking is a very important part. In women with regular menstrual cycles, you can actually say that most of them will probably undergo ovulation. And if you really want presumptive confirmation, I would say do a mid-luteal serum progesterone. I think that's enough. You don't need an endometrial biopsy. You don't need any other very hi-fi test to be able to determine that. Moving on. So what about ovarian reserve testing? Okay, this is interesting because, again, not every country or not every place in developing countries has access to the blood test we want. The 3 things we're going to look at here are AMH level, anti-Mullerian hormone, an antral follicle count, an AFC, which is ultrasound diagnostic indicator, and FSH, or follicular stimulating hormone. So which of these 3 actually give you the best view? Now, it's very important if you look at the highlighted portion that diagnosis of low ovarian reserve should be based on age rather than diagnostic tests. What does that mean? It means that you shouldn't routinely test everyone for AMH and antral follicle count if they're not above the age of 40. Obviously, if there are parts in an ultrasound, you pick up something abnormal and you want to do an AMH, that's fine, but this shouldn't be a routine. Moving on. So if you look at this particular slide, among the 3 tests I mentioned, you can see that both the highest sensitivity and the highest specificity are in doing AMH testing. AMH testing is probably the best test for ovarian reserve because it doesn't vary from month to month like FSH, which can be influenced by things like sleep patterns, eating habits, stress levels, and so on. And AFC as well is operator dependent on doing the ultrasound and can vary between months. And that's why AMH is probably the best way to go. All right, next. Okay, now we come to part 2. Now this is quite important, assessment of tubal disease. It's very important to diagnose someone with unexplained infertility only after making sure that their tubes are working. You get a lot of people in our part of the world that actually have tubal dysfunction, either because now of the rising rate of sexually transmitted infections or endometriosis around the world, as well as a larger portion of women having abdominal surgery. Therefore, the risk of tubal dysfunction is much higher these days in the developing world, not just in the developed world. So your 2 methods of assessing this are a hysterosalpingogram or HSG or a hysterosalpingo contrast sonography. It's called HICOSI, it's called HIFOSI in some parts of the world, can be used. Between the 2, if you look at the sensitivity, it's almost equal. And if you look at the specificity, again, it's almost equal. What I will share, though, is there is a caveat there to almost being equal. The HICOSI or HIFOSI must be performed by a trained operator. It is quite operator dependent, whereas the HSG is less so. So I find that in developing countries, a HIFOSI or HICOSI is easier to do because you don't need an X-ray machine, but you need more operators that are skilled in doing it. B, a HSG would give you a better result, but again, you probably would have to have an X-ray machine to be able to do it. Okay, next. What about cavity disorders? This is a little bit more difficult. I think we all determine it using our 2D scans. If 3D scans are available, that would be great. But if they are not, then some people like to do saline infusion, sonohysterography, but not many places around the world, again, have the facilities for that. A 3D ultrasound would be great. ASHRAE does recommend that. MRIs are not recommended as the first line. Obviously, if you're in a center that has it, that could be your diagnostic tool. And if an ultrasound is normal, usually no further evaluation is needed. Next. So again, this is just comparing the 3 things, the SIS, the 3D ultrasound, the 2D ultrasound. The hysteroscopy obviously has the highest amount of sensitivity and specificity, but you will need specialized equipment for that. It can be done as an outpatient procedure with sedation. It can be done under anesthesia, but either way, there is specialized equipment required. So not all countries can have that. If you don't, a 2D or 3D ultrasound is actually useful enough to be able to pick up uterine cavity disorders. Next. Now, this is a very key part of us diagnosing that a woman is actually unexplainedly infertile, and that's an assessment of a hormone. Her HPO axis, or the hypothalamus pituitary ovarian axis, is a very important point of care for you to be able to determine if the woman is having regular ovulation, can produce oocytes, and can actually get pregnant. The tests that we do are a day 2 FSH, a day 2 LH, and in some cases, estradiol and testosterone. Now, you can do thyroid function. I do it routinely. I think it's an important test. Obviously, if you had the facilities for thyroid antibody and autoimmune tests, that would be great. But I don't routinely do that. I do that for women with recurrent miscarriages or recurrent implantation failure. Testing for anti-sperm antibodies in either the male or female is not recommended. Next. So this is the WHO algorithm for male infertility. You can see that it's slightly more focused. The first 2 parts actually look at very good history taking, medical, reproductive, and sexual history. And part 2 is a focused physical examination. And if you pick up any relevant abnormalities from this, then you would refer this patient to a male infertility specialist. The third part is the part where I'm going to focus on. We do a lot of basic semen analysis. I think even in the most rudimentary centers around the world, we're able to do a basic semen analysis where you can see if the semen parameters are within the normal range or outside. So you can see that from this particular algorithm, if they're outside the range, you would repeat them. And if they're still outside, they would have to see a male fertility specialist. And if they're within the normal range, then you would manage the female infertility or manage them as unexplained infertility. Okay? Next, yeah. So what about the assessment for male factor? I think the semen analysis is the one basic, very important thing that we should be doing. You have the normal figures here. I'm not really going to go into them, but just very quickly, volume 1.5, total number of sperm is 40 million, but around the world that's going up slowly. Total motility is about 42% now, progressive motility at 30%. So these are all very basic things. I think around the world, we are all following the WHO recommendations for semen analysis. Next slide. So if the semen analysis is normal, the following tests are not recommended. I know we are moving to a day and age where everyone wants to do more and more tests, but these are not recommended. Testicular imaging, sperm DNA fragmentation, anti-sperm antibodies, HPV testing, hormonal testing, and so on. So these tests are only to be recommended if they have very abnormal semen analysis parameters and if your center has the ability to do them. Next. So what are the diagnostic boundaries here? It's a time threshold. We obviously say 12 months, but for certain patients in the older age group, you probably approach that a bit earlier. Maternal age limit is a big threshold. WHO takes it as below 40, but I think in your practice, you'll probably see a lot of patients that are 42, 43, and that's very important. Ovulatory function is important, tubal patency is important, male factor. If you've gone through all this and found out a single abnormality, you arrive at our diagnosis of unexplained infertility. Next. So now we're going to talk about patient values and constraints. Next slide. So what are the values and preferences? Now, we live in an era of shared decision making. It's no longer the doctor just saying, let's do this and everyone following. We need to speak to the patient about individualized care. We need to be able to provide them with prognostic data. And of course, their time preferences. How soon are they looking to get pregnant? If you have more time, you can do maybe a lesser form of treatment. And if on the other hand, value-driven anxiety is high, you think you've got to get moving, you can offer perhaps a more advanced form of treatment. And weighing efficacy against invasiveness is a very important part. Lifestyle counseling and psychological well-being. Next. So if you look at this particular slide, this is a pictorial representation of that. You've obviously got physiological and prognostic factors, which are age limits, duration of fertility, raw ovarian reserve. Then, very importantly, behavioral lifetime. I just had a patient who managed her diabetes. Her husband took a bit of Profertil, and they came in pregnant 6 weeks after. No IUI, no IVF, not even any ovarian reduction agents. So behavioral lifestyle changes, getting BMI extremes to change, quitting toxic exposure, coital frequency, these are very important. Safety and physical risk, whatever we do, we try to prevent risks such as OHSS, such as multiple pregnancies. So low dose regimens where we can. Psycho-emotional foundations are very important. You have to have a counselor. You have to be able to speak to the patient to address their concerns. And then, of course, socioeconomic. Not everyone can afford IVF or even IUI treatment. Geographical considerations are important. Next. So these are the boundaries. This is a diamond that I made up. This particular infographic was made using notebook. You can see it's divided into physiological, which is the patient's physical condition, psychological, how the patients are actually taking the treatment, behavioral, what we can change, and finally, socioeconomic. Next. So then we come to individualized management. Next. So expectant management is recommended by WHO, which means if you've diagnosed unexplained infertility in a patient, and they are reasonably young, between the ages of 20 and 35, 36, 37, 38, expectant management should be the first line of treatment. And only after that, IUI is recommended. Although WHO does recommend it as a first line treatment, they ask you to pick your patients carefully. And obviously, even when you lose low dose gonadotropins, you must look out for OHSS and try as far as possible to avoid multiple pregnancies. Next. So again, WHO recommends that you do not offer ovarian stimulation as a standalone treatment. It should obviously be together with follicular tracking and triggers where necessary. IVF is not recommended over IUI with ovarian stimulation if that's available. If the patient has unexplained infertility, again, it depends on the patient profile. And you can consider up to 4 cycles of IUI with ovarian stimulation. This is good because in a lot of countries, IUI is a far more affordable modality of treatment than IVF is. So obviously in the younger patient age group, you can look at the pregnancy rate down there, 18 all the way up to 37, you're getting good pregnancy rates in IVF, of course, and from 38 to 44, it starts dropping. Next. So what are the individualized management strategies according to invasiveness? Expected management is the best. IVF, of course, is very invasive. In terms of cost, expected management is minimal. IVF is highly restrictive financially. And guideline, obviously, the NICE guideline recommends 1 year in young couples and recommends IVF only after 2 years. The graph that we left out, of course, is success rates. And expected management does have relatively good success rates, but IVF would obviously be higher. Next. So this is the X-IUI trial, which showed that IUI with ovarian stimulation actually offered poor prognosis. So this is different from what WHO ordered. I just wanted you to have both sides of the coin here. So when they did IUIs for unexplained infertility, Mazzarotti looked at this in 2024 and found that actually it was poorer prognosis, but did show higher live birth rates in that. So in answer to the question, should IUI be routinely recommended? I still would go with the side of WHO, and I would recommend IUI, especially in a low-income setting. Next. So this is all shared decision-making. We live in a day and age where we give the science, we use the clinical guidelines, but we speak about it all to the patient, the human. We look at their patient values, and then we come up with an individualized treatment plan. Next. So in summary of what we do, just about a minute and a half left. Let's go through that. Next. So definition and criteria, it is a diagnosis of exclusion. All couples need to be screened. And if the female and male partners are found to be normal in terms of all the parameters we mentioned, tubal function or ovarian function, or no ovulation disorders, semen analysis, uterine cavity abnormalities, then they are explained to be unexplained infertility. And then we go to the first line treatment, which would start with expectant management, perhaps ovarian induction, and then IUI. Next. These are some of the babies we've had here in Metro IVF in Malacca. Of course, we try not to have multiple pregnancies, but as much as we try, sometimes God knows better. We put in 2 embryos for that picture in the center, which the 3 babies were born. Unfortunately, 1 split. And they make for good pictures, but I always like to use this as a warning of sorts that multiple pregnancies can still be difficult. They are very beautiful. And if you look at the amount of joy it brings, it's fantastic. But multiple pregnancies can be very difficult. And the risk of OHSS is something we should always look into. Next. Okay, these are the references we use. All right, that is exactly 20 minutes. I hope all of you benefited from that talk. I'd like to once again thank the Merck Foundation for inviting me to give it. I look forward to meeting you all in person one day, and you can contact me either through the Merck Foundation or through MSAT anytime you need. Thank you very much and have a good evening.
Thank you, Dr. Praveen Prabha, for this wonderful presentation. Would you like to add something else, sir?
Thank you very much, Dr. Sri. I think what I would like to add is, I think the most important take-home message is every country has different ethnic divisions and different types of fertility issues. Take what you want from whatever's presented and use the best that's available to you. Obviously, certain countries have some restrictions and certain countries do not have those same restrictions. So always cherry pick the best things you want and then treat them. If it's unexplained infertility, again, start off with just normal sexual intercourse, no intervention until the point where you think, okay, they need IUIs and subsequently IVF. I really do hope that talk has benefited you all. Thank you very much.
Thank you so much, Dr. Praveen.
Please welcome our next speaker for the session, Dr. Dakshanya Prathipan, Assistant Professor, Center of Excellence in Clinical Embryology, Department of Reproductive Science.
Good morning, everyone. I'm Dakshanya Pratibhan from Center of Excellence in Clinical Embryology, Kasturba Medical College, Manipal. Today I will be talking about advances in sperm selection technologies and how they can improve the ART outcomes. I will briefly cover how sperm naturally mature and why selection matters in the laboratory environment. I will also discuss the limitations of the existing methods and then move into the emerging technologies to identify top quality spermatozoa. So do you know something? There's a popular idea in ART. Give me a single good sperm and I will give you a pregnancy. But in reality, identifying that one ideal sperm is much more complex. Well, like many innovations, this is going through a hype cycle. We know that sperm are produced in millions, but most are functionally incompetent. We still don't have a reliable, non-invasive way to select the truly normal sperm. And importantly, sperm are transcriptionally inactive and so we can't assess them like other cells. So when we look into the physiology, spermatogenesis takes about 74 days in the testis. But sperm are still not functionally mature at this stage. They spend another 10 to 12 days in the epididymis, which is a highly coiled duct about 6 meters long. Here they undergo the final biochemical maturation. This sperm transport is a very active process. It is driven by ciliary movement, hydrostatic pressure gradients, and rhythmic smooth muscle contractions. This is regulated by both hormonal and neural factors. But as they progress, the motility pattern will change, and by the time they reach the chorda, they acquire forward progressive movement. It's important to note that they also gain the ability to undergo acrosome reaction, which is essential for fertilization. While we know that epididymis is crucial for sperm maturation, it's also important to note that here is where DNA damage can also occur. For instance, abnormal chromatin packaging makes sperm DNA more vulnerable, and factors like oxidative stress can also increase fragmentation. So ejaculated sperm has more chances for having higher DNA damage than the testicular sperm. Adding on to this, disruption of the epididymal environment can further increase the DNA damage. So this stage is both essential for maturation and also critical for maintaining DNA integrity. Clinically, evidence shows that higher sperm DNA fragmentation has been associated with recurrent pregnancy loss. This shows that even if fertilization occurs, the downstream outcomes can still be affected. Well, at the molecular level, sperm function depends on tight chromatin packaging. Here, histones are replaced by the protamins in order to protect the DNA. But histone retention can also occur, making DNA less compact and more vulnerable. A study done by our research group has shown that differential histone retention can negatively impact the sperm function and embryo quality even in the normosospermic cohort. And another study from our team shows that sperm characteristics in normal and abnormal ejaculates are differently influenced by the length of the ejaculatory abstinence. This brings us to an important point that standard semen parameters don't always reflect the fertility potential. This is what we call idiopathic male infertility, highlighting the gap in our current evaluation methods. So if everything appears normal in idiopathic infertility, what are we still missing? The answer may lie in hidden functional defects such as the impaired Caspar channel activity in the sperm. So what is Caspar? It is the principal calcium channel present in the sperm flagellum, specifically in the principal piece of the tail. It plays a very important role in regulating calcium entry into the sperm. This calcium influx is essential for activating the hyperactivated motility, that is a vigorous and asymmetric movement that allows sperm to effectively navigate through the female reproductive tract and then penetrate the oocyte. For example, cats for intact sperm initiate hyperactivated motility and allow sperm to move through their female reproductive tract and penetrate the oocyte. Whereas the cats for defect sperm may look morphologically normal but fail functionally. In contrast, in the laboratory environment, our sperm selection techniques, although it is very essential, can sometimes unintentionally impose stress on the sperm. For example, procedures such as repeated handling, pipetting, and especially centrifugation expose sperm to mechanical forces that the sperm would not normally encounter in the in vivo conditions. So when we look into the swim-up technique, here it selects the motile sperm, but they are not necessarily genetically normal ones. And when we focus on the density gradient centrifugation, this can lead to generation of reactive oxygen species, leading to oxidative stress. And then coming to ICSI, this relies on visual selection at low magnification, and IMSI, though we look into a higher magnification for sperm selection, the process is time consuming and doesn't guarantee a sperm with high DNA integrity. So overall, we are still selecting the visually normal sperm and not necessarily the functionally competent one. As when we look into the physiological tract, sperm undergo a highly selective multi-step filtering process. This is based on function, motility, and interaction with the environment. This natural selection is far more refined than what we currently achieve in the lab. And that's what we are trying to replicate with the emerging technologies. Goal in the lab is to replicate this natural selection as closely as possible. This is where microfluidics comes in. Devices are designed to mimic the physiological conditions and allow more natural sperm selection. There are different microfluidic designs used to allow for controlled flow in order to separate the sperm. For example, they use the controlled fluid flow where the sperm exhibit rheotaxis. That is, the sperm swim against the direction of the flow. And here only the sperm with better motility and functional competence can overcome this and move forward. So this system allows sperm to self-select under conditions that closely resembles the natural environment. Additionally, there are some devices that are adapted for ICSI procedures using rheotaxis in order to help select the functionally competent sperm during the real-time procedures. Additionally, there are also several other microfluidic strategies for sperm selection in the in vitro conditions. So when we look into the chemotaxis based method, the sperm are guided by the chemical signals. For example, the sperm travel towards the higher concentration gradient, here which is marked as the attractant. Next, when we look into the thermotaxis based method, the sperm move along a temperature gradient, typically towards the warmer regions, towards the oocyte. So here, in order to mimic this, we have the microheaters in the microfluidic device. There are also devices like that mimic the chemotactic structures. For example, the microchannels with diffusion chamber, which mimics the uterus, and bibranch channels, which mimics the oviducts. These are present as one microfluidic chip, and the cumulus cells are added as the chemoattractive source to investigate the sperm motility. There are also structures that mimic the microscale grooves. So these surface grooves will guide the sperm movement, physically aligning and directing motile sperm in the forward direction. There are also structures that mimic the uterotubal junction. So here there are probes with angles of 20 degrees, 30 degrees and 50 degrees, which are fabricated to form a uterotubal junction and trap the sperm. There are also devices like the spermometer, which consists of two main channels. The spermatozoa are trapped in the interconnecting channel because of the higher fluid flow in the bottom channel. So these electrode rays are used for differential impedance analysis. Altogether, these systems help in order to guide the sperm through microchannels that will be similar to the in vivo sperm selection. But how strong is the evidence? That's still an important question. A clinical study shows that microfluidics tend to yield fewer sperm compared to the conventional density gradient centrifugation. But it is important to note that though few in number, they are of better quality in terms of motility and improved DNA integrity. This shows that microfluidics prioritizes quality over quantity. Studies have also shown that microfluidic-based sperm selection improves the quality in terms of better motility, morphology, and embryo outcomes with reduced DNA fragmentation. This also translates to improved implantation, pregnancy outcomes, and live birth rates. Further, a study done by our own team has shown that microfluidics has improved viability, longevity, which is around 6 hours and 18 hours post-extraction, mitochondrial function, and also reduced the DNA fragmentation compared to the conventional methods. Further, an emerging approach in sperm selection is the use of artificial intelligence combined with high magnification imaging. Here, the sperm are assessed for morphology and motility more precisely than manual selection. So, this reduces the subjectivity. Some systems are also integrated with the robotics for automated selection during the ICSI procedure. Interestingly, a clinical report revealed that artificial intelligence for sperm selection has improved the blastocyst formation, particularly in cases with poor oocyte quality, unlike the donor cycles. So this gives a better way to select the sperm, specifically in case of a poor gamete quality. Additionally, the challenge comes when working with the TZ samples. The challenge is not just about finding the sperm, but about identifying the functionally competent ones among the very few and often immotile cells. So this is where the microfluidic technologies becomes valuable. A clinical report has revealed that microfluidic systems can also reduce the somatic cells and debris and increase the efficiency. This microfluidic device yielded about 8.8-fold improvement in the sperm found per minute. While microfluidics mimics natural selection and improves quality, it also comes with some challenges. It includes high cost, lack of standard protocols, and limited large-scale clinical evidence because there is no sufficient information on the sperm viability and motility. So the question still remains if microfluidics and AI is truly the future for sperm selection. Well, if you ask me, the advancements are promising, but clinical translation still needs more strong evidence. Before I wind up, I would like to acknowledge our team headed by Professor Satish Kumar Adiga. And I also extend my thanks to Professor Schlatt of University of Münster for his collaboration. I also extend my gratitude to Merck Foundation for the opportunity to share my views. Thank you everyone for your patient listening, and I would be happy to take in any queries.
Thank you, Dr. Dakshana Pradeepan. So now I would like to invite our next speaker, Dr. Vipin Chandra, Chief of Clinical and Lab Operations, Indra IVF, India, to present the topic Artificial Intelligence and Omics Technologies in Assisted Reproductive Medicine.
It's a pleasure to be part of this session. Today's my topic is about artificial intelligence and mixed technology, which may shape the future of AR in a large way. What we are, or how, basically, what was the status and how it's gonna shape in future. We will deep dive into it. So this is my disclosure. There is no conflict of interest. So elements. ART seems to be little among all alternative legal most paternity, where just we have to do IUI and make embryo and then transfer. That's all. But it's not so. But it is very very complex over here. Two types of being estimated is different. The sperms have a may have different competence because the DNA fragment the embryo form because of the as well as the anatomical condition in the laboratory as well as management with through and those sites are being produced may have a difference in genomics, in metabolic conditions, actual competence to go into and deliver as a live birth. Although these also there is then endometrial and embryonal receptivity and crosstalks, which again plays a role, and that's why because of these complex, these immense biological complexities, lot many people face infertility problems, and there are a lot many unmet needs are there. So these unmet needs in the ART because right now also around 50, globally there are 15 to 17% of the globals are there which are having infertility issues, and among the good blasts also even with the good blasts they are only the 50-60% maximum can do the get implanted. Embryos can have a variability in terms of the aneuploidies from starting from 40% to 90% as the age increases. And all these variations lead to the recurrent failure out of the total infertile couple. Around 25 to 30% patient may faces the recurrent implantation failure. With all these unmet need, there's a lot of things to be done. Are there because doctors may not be vulnerabilities, needs. All these things can be managed by AI through AI in some way. As we were discussing, there are a lot of data available, and all these data sets which are arising from the clinics, from the images, from the genomic labs, from the laboratory and outcomes. All these needs to be like from the clinic. We get in the infertility history, age, AMH, receptor polymorphism, hormonal profile, previous outcomes, imaging. Like we have to have an sagittal views how the endometrium is look like, what's the vascularity, what is the PI, RI, and all. Genetic data wise, like whether there is a receptor polymorphism, whole gene, whether the aneuploidies have come up in the ormosism has come up on the embryos or not. Laboratory data where the culture conditions are well or no good enough, and during the when the embryos have been cultured in the incubators, all these data would ultimately impact the outcomes in terms of clinical implantation, pregnancy rates, and the miscarriages, and so and so. Now, all these put together need to have we need for a human cognitive brain. It's difficult to consolidate all these information and make a decision. Now, this is where the AI synthesis engines can help us out. They can do this analysis very precisely and in a standard way, which is without having much being get biased, get interrupted, because it keep on learning from the previous data, and without getting fatigued, it will give you the same outcome, predictive outcomes for each and every condition. So this is why this is the table which I'll want to show you why the AI is going to help us immensely, because in any kind of in traditional assessments for any fraternity, but especially for the ART. Why? Because a lot of variables are there during the traditional assessments. We are subjected to the cognitive biases, inter-observer variabilities, the variable variation due to the fatigue, the mood, and some biasness because of the learning also. All these can be can be precisely taken care of by the AI engines now, which will provide you standardized and standardized solutioning. They will not get fatigued. They will be definitely scalable. They will they will give the predictable outcomes across all the cycles, and that's where the AI wins over the humans. Now we know that in AI there are many toolkits are available, and all of them have some or more other applications in the reproductive medicines, where we have machine learning, deep learning, computer visions, NLP, which is natural language processing, fundamental models, foundation model, generative AI. All these have certain rules and applications in a reproductive medicines. So one and foremost important example of how AI is helping us out to that. Take an example of ovarian stimulation. Now, ovarian stimulation, we know that it's been there are a lot of variations are there, a lot of factors which affect those ovarian control ovarian hyperstimulation, age, AFC, AMH, BMI, genetic polymorphism, previous hypo response, and all, and hormones which are been coming up in these cycles. So there are cyclic variations are coming. Now, all these things can be easily managed by machine learning tools, which are much better than the traditionally used logistic regression analysis. And these things will really can easily predict on what is going to the oocyte, they will can predict out, but the possible poor responses, hyper response, and OHSS risk. All those things can easily be predicted. Even now, much more than these, now the AI tools are coming up where they can predict, they can suggest clinicians what should the protocol and the starting dose of the gonadotropin to be used for this particular patient, basis the previous history and basis the patient profile and the clinical investigations, and what next dose to be given, when should be the next visit to become, it without the use of follicle and without the use of the follicular monitoring and the hormonal monitoring. So these are the advantage which may come up in our routine clinical practices. Some more case scenarios are there where precision stimulation and implantation predictions can happen basis the so for example, in case of an implantation where we know, where the system knows from the previous learning endometrial parameters about the clinical history as well as the embryo variables, and then they can do the prediction about the each and every individual, what is the probability of implantation in such cases. So these are the certain case scenarios which are now very well in the market, readily available in the market for use, though there will be some in some scenarios, since all depends upon how, on what kind of how much volume they have been trained about, what is the algorithm like, and so that basis this they have their own sensitivity and specificity and the predictive values. But the good part about the AI is that the more and more data is been utilized to get them trained, the more they get better and better with the time. Another very simple tool which we all of us are aware of, that we know that there are for embryo selection and assessments, we all were dependent on the morphological grading, and these morphological gradings were having a very much inter-observer variations, And these, even on the morphology basis, we were unable to predict the predictive value of implantation, successful implantation, ongoing pregnancy, and live birth rates. And having being this euploid as a number just on the basis of the your morphology, this embryo being an euploid one, that predictive value is also very low. Now, considering all these things, there are tools available where there are AI platform available with which are using on the 2D static images as well as the time lapse loops, which can score basis the ICM, trophectoderm, and the blastocele and their morphological parameters, and give the scoring around how this embryo is going to be with about the euploidy, also about the implantation and the live birth. So as well as the possibility of or the prognosis of freezing them and then giving a live birth. So a lot many tools are available in the present era to start using them, and they are pretty handy and with the pretty good predictive values. So time-lapse is another example of how machine learning and the AI is coming into in our routine practices. We know that we are traditionally doing day three evaluation and the blastocyst evaluation, but the time lapse is a next level where the continuous time lapse image from all 5 days, where all the morphokinetic changes have been captured. The system knows is there any giants has been formulated during the journey of the embryo formation, asymmetric division of the embryo and the nuclei happen. All these are the which are the predictive marker for the embryo being not being good. All those been taken into consideration, and then these time lapse can give us an idea around running on the algorithms about the possible embryo competence about the on the ART outcomes. So that's where AI wins. As I can say, there are though the human clinicians or embryologists, they can still have a clinical context, ethical judgments. They can do a case-to-case basis variations can be there, but those are limited. But here, AI, what brings AI on the table is consistency, predictability, and without fatigue, they will give outcomes. And so that's why in certain scenarios now AI is becoming a new clinical gold standards. Another good example is where we know that the algorithms are there, which once the NG has been run, PG embryo biopsy has been taken, we know that the embryo is either genetically normal or not, means structurally, and then on the numerical side of the chromosomes, whether the all the whether the embryo is euploid or not. But now we know that assessing the euploidy will not let us know the embryo competency, or many euploid embryos get fails. Almost 30-40 embryos which are euploid still did not get implanted. Now all of these can be further, when the embryo competency can further be improvised using various omics like transcriptomics, proteomics, metabolomics. On these can put on algorithms, can use an embryo competence for the implantation and live birth. Simultaneously, they can give various algorithm with the SNPs can give us a polygenic risk scoring. So all these will help us in upcoming years, that where we can just not give a pregnancy, we can ensure that the pregnancy out of this pregnancy, the progeny which is going to come into the world will be more healthier than routine IVF. So as I discussed in my last slide, there are multi-omics are coming revolutions is coming. So there are genomics, there are transcriptomics, proteomics, secretomics, metabolomics, and epigenomics. All these genomics, omics together contributes to assess the embryo in a better way. So as you can see in this, in the precision reproductive medicine, which will allow us to have a more precision selection of the embryos, There can be proteomics, which let us know about the protein being secreted, and it's all of these will be non-invasive, because without invasion we can know the proteins which are being secreted in the spent media. We can get the information about the competence of the embryo. Secretomics, like cell-free DNA and exomes. Epigenomics, methylation imprintings. Genomics, where the genome DNA which has come into the spent media, and as well as the PGTA, PGTM can give us an information. So is the transcriptomics. Among them, the most important is the metabolomics and the transcriptomics. Why? Because genetic is one part, but with these genetics, genes or the DNA will come out, and give the competence through the RNA which are being found and the protein which are being found into metabolites. So actually, the DNA, with whether that's really working for the betterment of the embryo development, is been more remarkably come out once we know about the proteomics and the transcriptomics and the metabolomics. So these will give us a more better idea around the embryo competency than just the genetics. So if all these put together, now algorithms have been created which can help us in predicting in a more precise way about the embryo competence. Among the omics, genomics is the one which we are right now using. So there are PGT available, PGTM, PGTSR, PGTP, and NI-PGTs are available. But out of these, which are most commonly routinely used, is PGTA. But we have to think beyond the PGTA. We should go for a carrier screening, expanded carrier screening for the most of the couples, and so that we can select out the embryos which are having because all the people have a 1 to 2% risk of carrying and autosomal recessive traits. All these can be omitted with the use of extended carrier screening. And once we know which carrier screens are there, carrier genes are there, we can allow PGTM to happen on the embryos, so that the good embryo and the healthy embryos without having any recessive traits can be selected for the progeny. So is with PGTSR, PGTP. PGTP is a nice, intriguing concept which is coming now. This allows, which bases the various SNPs present in the DNA. Those SNPs will be put together into the various algorithms. Will get information about the risk of a long-term diseases or adulthood diseases which are polygenic in nature, can be assessed through PGTP. Though this is very new, it's still in the research level, but I can foresee that this going to the future, where we can predict that among all the embryos available, which embryo is having a high risk for the cardiac disease, high risk for the diabetes, high or cancer, and then we can select among these which is the euploid, which is not having a genetic carrier mutations, or which is not having a high risk for the polygenic disorders. Such embryo selection will let us to help us to have a more healthier offsprings than in the present era. As I said, transcriptomic and the endometrial receptivity is another way are giving us a more advanced and better update about the competence of the embryo as well as the endometrial receptivity, because these are the RNAs and the proteins which really manifest on the implantation, which help us, like in cases of addition molecules, all those are actually the RNA and DNAs. Through the DNAs, the RNAs and an RNA protein. So these assessment of these will help us in more understanding about and better understanding about the receptivity. So is the metabolomic, proteomic, and secretomics, because these all will help us give understanding whether though the embryo is genetically normal or it's still dividing and having a good proteins. Does the metabolomics or proteomics allowing us to know whether whether the embryo is having enough metabolic competence in form of mitochondrial index that they are able to survive the implantation. So what we can foresee in future, that all the omics can be integrated with an AI and gives an ultimate embryo scoring with the help of genomics, transcriptomics, proteomics, metabolomics, and morphokinetics put together, an embryo can be selected, which will be much more robust way to select the embryo for transfer. We have already discussed that the AI-driven clinical decision support systems they're already are in practice now, but the way they can help us is that there are tools available now who can support us how to do the ovarian stimulation, who can monitor the ovarian response and understand, predict the oocyte yields, implantation and transfer decision through the transcriptomics and all, and even for the labs also there are AI tool now which are been there in which can predict basis the VOCs, other gas qualities, temperature, humidity can then predict the outcomes of the embryo, and they can allow you to do the preventive actions before the things go wrong in the lab. So going forward, I'm seeing a scenario where we have everything been every information, be it coming from genetics, be it coming from the lab or from a patient profiling, all these being together put together will allow us to have a digital information of embryo to do the selection of the embryo. Similarly, as I discussed, now the autonomous AI laboratories, the possibility in the near future, where studying the VOC trends, we're studying the humidity trend, O2, CO2, temperature trends in the lab, they will allow you to give a preventive maintenance feedbacks when to intervene. Otherwise, the culture conditions will go haywire, and it going to affect the lab. So all these things which are beyond right now, presently we are beyond the scope of a human being cognitive assessment to do these preventive changes. We know we do always have a always react to what is happening. Means the VOCs were high, so the embryo got deranged. Humidity was high, so the embryo not formed. But now with the AI, we know real time information, and we can even not real time. We can have a preventive information to do the corrective actions before anything got damaged. So we know that along with the all these form, the witnessing is one very crucial part of the ART, which is unlike other fraternity, where we know that presently it's all about manual, where the two witnessing or three witnessing has been done. But gradually, we are moving now. The world is moving towards the RFID and electronic witnessing. Now, but in future, what I can think of that even along with the RFID, genomics and proteomics can be a part of a combined part of an witnessing system. So even the oocytes and the samples can be tagged, and they will be much robust. Along with these, as I discussed, there are commercially available and tools are available for empowering the patient for the decision making and giving them a prognostication about their conditions, what protocol should be best suited for them, what will the prognosis for the oocyte yield and the embryo formation in them, and the successful live birth basis their clinical profiling. So all these tools are again AI, which help the patients in making an informed decision. What kind of a treatment they should take, how many cycle they should avail. Should they go for a donor oocyte donor program in an early stage or not? So all these things are right now helping tools which helps patients to take an informed decision about their reproductive potentials. On the ethical issues, definitely whenever AI comes in a picture, we always discuss about the ethics, because it should not be misused. A major concern for any nation or any patient is about the data privacy. I feel like countries, just like the developing countries, I think everybody will be come at par to have their own country laws which will allow us to have ethical guardrails where AI can be used for the betterment of the patients. So this is the blueprint which I think of for a 2035 where IVF clinic, how it will be like. There will be digital fertility assessment will be there, profiling of the patient can be done, prognostication of the patient can be done, treatment making analysis will be done through the AI use of AI, precision stimulation will be done through the use of AI systems where protocol being designed, the drugs and all triggers and all will be decided by the AI protocols. Then embryo selections will be through the use of AI, and lastly, endometrium will be assessed which window window of endometrium is best having the best window of implantation, and all these put together, all these things will be decided how best by the AI rather than the clinicians who will be just doing the pickup and the transfers for them. And maybe that will also be taken care by the robots maybe in future. So this is a transition which is coming from a descriptive from a discipline to the predictive science, which is evolving with the AI. And I foresee these changes may come up in our practices soon, very soon, maybe another 7 to years. AI will have a lot many says in our practices going in future. So key takeaway from my topic today is that we don't have to shy away from the AI. It's not going to replace doctors. Doctors will still be doing the counseling and the prognostication, but yes, they will be taking help of these two AI tools, which will definitely add value to their practices rather than being competing with the doctor themselves. So AI adds value will, as I said, it will help the doctors in plan making, embryo selections, and the endometrial receptivities, so that the overall the prognostication and the outcome wise, some more cases can be made positive, and the overall implantation live birth rate for most of the cases may go a little better. So these are the references for your for this presentation. And with this, I end my presentation. Thank you for giving me opportunity to present to such a large gathering. And it's always pleasure to give awareness around ART to our fellow Africans. Thank you.
We have a Q&A from Mr. Arafat Atuman. His question was, can we use AI to select day 3 cleavage stage embryos, or it's only for blastocyst stage only? And if it's so, could there be any cost issues? It was his question.
Presently, whatever the AI tool which are available in market, since the world is moving from day 3 transfers to the day 5 transfers, so no one is putting money on that on assessing the potential of day 3 transfers. And more so, it's very right also that the transition from the heavy maternally influenced DNA and embryo and meiotic cleavages, transition from that to individual embryo DNA dependent cleavage system, which happens on day 3. It's always good to have a blastoceless transfer practice, and that's why everybody is putting money on the on the blastocyst assessments. That's all from my side.
Thank you, Dr. Vipin Chandra, for sharing your valuable insights. Please welcome our next speaker for the session, Dr. Nidhi Sharma, Professor of Obstetrics and Gynecology, Savitha Medical College, Chennai, India.
I'm Professor Dr. Nidhi Sharma from Savitha Medical College Hospital. We'll discuss the precision management of diminished ovarian reserve, integrating Poseidon stratification, duostim protocols, and adjuvant therapies. So in this meeting, I will cover the Bologna criteria, the Poseidon criteria, the stimulation strategies, double stimulation strategies, testosterone priming, DHEA, growth hormone, oocyte banking accumulation, and the donor program for the poor responders. So, poor ovarian response lacks a standardized definition. Poor responders constitute a heterogeneous cohort with a common denominator of under-responding to controlled ovarian stimulation. The incidence is generally estimated to be between 9% to 25% of all IVF cycles, though some studies suggest it may be as high as 35% depending on the definition used. From this criteria employed for the diagnosis to the plethora of strategies and adjuvant therapies proposed, the conundrum of poor ovarian responders still puzzles the practitioner. So, it is common in older women and it also affects 10% of young women. So, in the Poseidon impact, it is estimated that 47% of all ART patients belong to one of the four low prognosis groups. And poor ovarian response is also responsible for 20% of all IVF cycle cancellations. So, we understand the burden. The pathophysiology could be from ovarian aging, which is natural or accelerated due to follicular atresia. It could be genetic or molecular factors like FSH receptor polymorphism, or it could be acquired and environmental factors like endometriosis and lifestyle, smoking, and obesity factors. Now, there is a chronological clock and a biological clock. The chronological clock is the actual age of the patient and it affects the quality, the aneuploidies ratios. The biological clock is what we assess by AMH levels, AFC, and the basal FSH. It derives a quantity of the oocytes which will be able to retrieve. Now, ovarian reserve test we know classically can be biological, biochemical, biophysical, histological. The two main criteria will be Bologna criteria and Poseidon. The Bologna was given in 2011. Now, this is any 2 out of 3. So, advanced maternal age more than 40, a previous incident of poor ovarian reserves, or a low ovarian reserve test with by AFC or AMH. Now, 2 of these 3 criteria puts the patient in poor ovarian response criteria. Now, if there are 2 previous incidents of poor response to IVF cycle, then also the patient is classified as poor ovarian responder as per the Bologna criteria. Now, this Bologna criteria had strengths. The strength was it was the first global attempt and it was accurate. The weakness was it clubbed together a very heterogeneous group of patients and it did not provide the next steps of treatment. It paved the way of further markers. It was a first attempt to standardize the AMH assays, and the threats were posed by the upcoming Poseidon criteria. The failure of monolithic design led to the development of the newer Poseidon criteria. Poseidon criteria has 4 subgroups. Group 1 is a young, unexpected poor responder whose age is less than 35, AFC is more than 5, AMH is more than 1.2, and this is a suboptimal poor young responder. Group 2 is an older, unexpected responder whose age is more than 35, AFC and AMH is normal. Group 3 is a young, expected, whose age is less than 35, but AFC and AMH is low. And Group 4 is an older, expected patient who's more than 35 and AFC and AMH are also low. The strength of the Poseidon criteria is it is integrating a lot of parameters. It provides opportunity to use the ART calculator. It has the weakness because it relies on arbitrary cutoffs, and the threat is that it makes the treatment a little expensive. Now, the key stimulation strategies, how to manage a poor response as per Poseidon, can be any of these options. Mainly, we'll focus on the double stimulation protocol. So, when you are dealing with a poor responder, first we try to increase the number of recruitable follicles, then increase the number of follicles being recruited during the ovarian stimulation, and of course, we have a focus on the quality of oocytes we are gonna get. So, androgens can be used as a pre-treatment measure because androgens help in the early follicular development, increase the insulin-like growth factor, and they increase the number of preantral and antral follicles. They increase the FSH receptor expression and potentially lead to enhanced responsiveness of ovaries to FSH. We can also use dehydroepiandrosterone in the doses as given here by the evidence suggested here. Now, we can also use androgen modulating agents like recombinant LH, HCG, or aromatase inhibitors, and these act by decreasing the conversion of androgens to estrogens, and they allow a large cohort of follicles to escape atresia. So, pre-priming can be done by androgens or androgen modulating agents. Coming to growth hormone, Growth hormone helps to induce the LH receptors and increase the synthesis of progestins and proteoglycans. So it can be given in 2 doses, 4 units from day 21 of previous cycle, or low dose growth hormone 0.5 units administered daily from the first day of agonist till the day of HCG. Antioxidants, L-arginine, vitamin E, myo-inositol, chiroinositol, carnitine, selenium, folic acid, omega-3, polyunsaturated fatty acids, coenzyme Q10, melatonin, resveratrol, dimethyl fumarate, advanced mitochondrial targeted antioxidants, including mitoquinone and ilamipretide, have various mechanisms of action, which I have elaborated in this slide. And they mainly work, the thickness of this arrow is the thickness of the evidence we have got against and for these drugs. And so basically they work by reducing the oxidative stress, enhancing the mitochondrial function, activating the dormant follicles, and preserving and restoring the follicle visibility, and improved ovarian microenvironment and modulation of follicle recruitment. So when we come to the matrix, so the adjuvants acts in these doses, and these are the biological targets. So this is basically priming the ovary and improving the quality of oocyte. Among the various stimulation protocols available to us, we will focus whether increasing the dose of gonadotropin helps in poor responders. So the answer is no, because we cannot flog a tired horse. You can only give it CPR. So at some point, saturation kinetics are attained, and increasing the dose of gonadotropins will not give a good or more number of oocytes. And so evidence from a lot of studies suggests that a very high gonadotropin dosage of more than 300 international units are unlikely to be beneficial. Doubling the HMG dose does not make sense. So we have been using agonists, classical protocol, but when it comes to poor responders, the classical protocol has some disadvantages. We are still using antagonist protocol. So some of the disadvantages, it can be profound suppression of follicles, and it can prolongation of follicular phase and significant increase in the dosage of gonadotropins. And there is also more chances of OHSS. When it comes to poor responders, we are with agonist, we can use a microdose flare when a leuprolide acetate 20 microgram administered twice daily with gonadotropins from day 2 to the day of trigger, or a regular dose flare with gonadotropins beginning with leuprolide acetate on day 2 at day 1 for 3 days and followed by 250 micrograms per day till the day of HCG administration. Now, antagonists, which is being used in our cycles, now, antagonists have been used because the agonist flare-up response is avoided, and it shortens the overall treatment period. Antagonists reduce the risk of OHSS, and they also reduce the menopausal side effects associated with agonists. Some people say it's a poor responder, so why not use just a natural cycle or a slightly modified natural cycle when we use minimal dose of gonadotropins and HCG in a poor responder, as suggested by the International Society for Mild Approaches in Assisted Reproduction. Innovative protocols include combining the microflare agonist with the GnRH agonist in the poor responders. So this innovative protocol is called as AACEP, that is agonist antagonist conversion with estrogen priming in poor responders. Now, estrogen priming in poor responders is required to get a uniform, homogeneous, same size cohort of follicles. However, this needs further studies and validation. Luteal phase manipulation is the priming. So before you start your protocol, you make sure all the follicles are of the same size. So we start estradiol from the day 21 of the previous cycle. This estradiol can be given as patches or as injections. So Poseidon strategies classify with the Poseidon criteria, estimate the number with an ART calculator, and then maximize the number of oocytes. So ART calculator can be a pre-treatment calculator or a post-treatment. In the pre-treatment ART calculator, we will enter the patient's age, and we'll enter whether the sperm was obtained by ejaculatory method or is it a TISA-PISA sample, and we will get an estimated number of oocytes required to get one euploid blastocyst for transfer. Whereas in the post-treatment ART calculator, we admit the actual number of oocytes obtained, a little bit details about the stimulation, and we get a percentage. Like in this patient, 54.7% is the chance of getting a one euploid blastocyst. So ART calculator helps us in counseling the patient. This funnel refers to the number of oocytes on day 2, the number of follicles before the time of retrieval, and this is the actual oocyte received. So the ratio of the oocytes per follicle is called as follicle oocyte index, and the ratio of oocytes obtained from the retrievable follicles which were more than 18 millimeter, that is called as a follicle output rate. So the two key performance indicators in a Poseidon criteria are taken as the follicle oocyte index and the Fort ratio. So how do we manage a group 1 hyporesponders? You can increase the recombinant FSH dose. You can use an antagonist protocol with estradiol or OCP priming to ensure synchronicity and fresh transfer. In more than 35 years, we have to use aggressive gonadotropin escalation, implement duostim protocol, and then we have to do an elective cycle segmentation by freeze-all. For a group 3 person, which is less than 35 years, we can give a priming by androgens growth hormone, and we can give high doses of recombinant FSH. Don't use urinary products, and if the follicle to oocyte index drops or insufficient numbers are retrieved, you can switch over to duostim. In the more than 35 years, straight away do duostim. Okay, so what is duostim? Duostim is based upon the new theories of folliculogenesis, which is a conventional recruitment theory of one follicle getting recruited. There is also a theory of continuous recruitment in follicles, and there are also a theory about the multiple waves of follicles. So if the follicles are getting recruited throughout in the cycle, we can stimulate a patient anytime in the cycle. So this is a classical duostim in which we do a luteal phase estradiol priming 4 milligram per day, and we started from the 21st day of the previous menstrual cycle. And once a patient start to menstruate, on the second day, we'll start with our gonadotropins, and then we'll give an antag to prevent the premature LH surge. We'll give an agonist trigger, do an ovum pickup. Now let the 5 days go. 2, 3, 4, and 5. As soon as the 5 days go, we start with the second stimulation, which is back to back. And this stimulation, we can give an agonist trigger or an HCG trigger and go ahead with the pickup after 34 hours. This is again a framework of duostim protocol where options have been shown for pre-treatment, which can be done with estradiol, GnRH, progesterone, ocipils. We can also give the stimulation options have been given here, and the idea of adding clomiphene and letrozole is to reduce the cost of the duostim. LH suppression outcome can be done with all these ways like GnRH antag, progesterone primed ovarian stimulation, and acids. Trigger can be agonist or HCG. So this is the surfing the follicular way. So the second stimulation starts immediately after the first stimulation. And this is primarily utilized for a time-sensitive, low prognosis patients with advanced maternal age to rapidly accumulate the oocyte and maximize the probability of reaching the euploid blastocyst threshold at the earliest possible. Now, why this duo stimulation works? It works because there is a better synchronization of cohort of follicles. There is a increase in the FSH receptors in the granulosa cell. The ovarian microenvironment is now more favorable. There are more angiogenic factors. There is an increase in the cells to FSH. And there is, because we have used an agonist trigger in the first stimulation of the duostim, it helps in the flare-up response of the second stimulation and helps us get more follicles. But more studies are required to confirm these assumptions. So duostim strength is that it decreases the cost of the cycle, and there is an increase in the total number of oocytes received. It promotes steroidogenesis and folliculogenesis in the cycle. It re-establishes the adequate LH levels. The weakness is that we do not know the sweet spot of the absolute LH levels, and this cycle has mostly been tested in advanced maternal age. There is also a concern about whether the oocyte from a luteal phase is as competent as the oocyte from the follicle phase. So various protocols have come. One is a random start protocol, which you can start from day 14 when the patient has spontaneously ovulated or when the patient has been made to ovulate by giving an agonist trigger. Another way of random start protocol is the late follicular start protocol, in which the endogenous progesterone are coming from the patient, and this patient has been stimulated in the late follicular phase. Now, this late follicular phase stimulation can also be done after a spontaneous ovulation when the antagonist has been added to prevent the premature surge, and a triggered ovulation when antagonist has been added to prevent the premature surge. Now, in the late follicular spontaneous ovulation, we can also add progestins from the beginning, or we can add progestins from later on in the cycle. Spontaneous ovulation and triggered ovulation, the patient can be stimulated at any point in the cycle, and the endogenous progestins can be supported by giving exogenous progestins to prevent the premature surge, and then trigger can be given. Now, the advantage of this cycle is it is preventing the use of antagonists, and so thereby reducing the cost of the cycle. So these are the various double stimulation protocols in which we have added the progestins, both endogenous and exogenous, and these two protocols are back to back. The first trigger used is always agonist. The second trigger can be HCG or an agonist trigger. Now, this is a Italian protocol. In the Italian protocol is the most expensive one. So we use gonadotropin antagonist and an agonist trigger, and then we do the ovum pickup. Whereas in New York proposition, it has been an attempt to reduce the cost of this double stimulation. So they have used clomiphene or letrozole in the initial stimulation and then added FSH and LH. And in the Shanghai protocol, they have used clomiphene, letrozole, ibuprofen to prevent the premature surge, and medroxyprogesterone acetate to prevent the premature surge instead of antagonist. So this drastically helps us to save the money. Now, coming to various advances, we obviously will prefer ICSI over IVF. There can be an AI-driven embryo selection. Time-lapse imaging can help us to select the best blastocyst. Embryo and oocyte pooling helps us to get more implantable embryos, and Freezol is right now we are using only Freezol strategies. So these are the innovative therapies about PRP infusion, in vitro activation, stem cell based therapy, mitochondrial therapies, and microRNAs. Other complementary therapies include stress anxiety management, empathetic counseling, and acupuncture. So donor oocytes programs have got high success rates. Suppose nothing works, then we have to go for donor oocytes. And fertility preservation for oncology patients, so duostim is very helpful. The patient needs psychological support. They need a lot of counseling. It should be a shared decision making, and obviously the data should be transparent, and this can be measured with the help of ART calculator. So the key recommendation is set the expectations using a pre-treatment ART calculator. Use a pre-stimulation strategy by priming with estrogens or progesterone or ossicles. Do a luteal phase synchronization. Do the stress management by using a pre-treatment ART. Do a duo-stim protocol. Continue the ongoing counseling with the post-treatment ART calculator, and be transparent with the data and tell the patient how many embryos they have got. So future directions include organoid models, personalized ovarian stimulation, stem cell gametogenesis, nanotechnology drug delivery, targeted stimulations, and digital health and AI dashboards. So this is the precision management algorithm based on Poseidon. So we stratify the patient age and we classify them into the 4 Poseidon branches. We give them the pre-treatment CPR in the form of antioxidants, in the form of ovarian rejuvenation, and then we stimulate with the help of duostim. We accumulate those oocytes. We find out what are the key performance indices going wrong, whether it is a follicle oocyte index defect or whether it is a follicle output rate defect. And this makes us to the takeaway that ovarian stimulation is no longer an empirical guess. It is precise, mathematically driven sequence designed to overcome biological deficits. So to summarize, there is no gold standard. Individualize the approach. Give duostim and dual trigger is promising. Adjuvants, use them selectively. Keep counseling the patient. And coenzyme Q10 needs more studies, though it has been used to resuscitate the ovary in an age-related decline of ovarian reserve. Melatonin has been used. A lot of melatonin gummies are available in the market, and this also needs a well-performed randomized control trials, which should be blinded, and then only we can comment upon the clinical pregnancy rate and other ART outcomes. Glucocorticoids seem to work in those patients which have anti-FSH receptor antibodies, or they are associated with other autoimmune phenomena like Addison's disease, thyroiditis, autoimmune polyglandular insufficiency. And in these patients, low-dose glucocorticoids in the form of dexamethasone 0.5 milligram given in the follicular phase from day 2 till the day of trigger will help. And traditional Chinese and Indian medicine use Suning, Dingkum, pill, and all these lot of research papers are given in the literature, but the specific mechanism is not yet explored, and we do not need to give them without confirming. These are my references. Thank you.
Thank you, Dr. Nidhi Sharma, for such a dynamic presentation. Please have some words and share your thoughts, Dr. Nidhi Sharma.
Okay, so I'd just like to summarize that this talk is about classifying the patient. So when you see a poor response to IVF stimulation, which is very common, around 1/4 of the IVF cycles get cancelled because of the poor response. So try to put them in one of the Poseidon groups. So if the patient is a young expected, young unexpected, old unexpected, then you have take the advantage of giving them the pre-stimulation adjuvant protocols, give them DHEA, improve the AMH, give them melatonin, coenzyme Q adjuvants, give them on the day 21 of previous cycle, start giving them ocipils, make the cohort uniform, and then start stimulating on day 2. And if the person is really like more than 35 years and AMH, AFC are very low, then we have to straight away go for duostin and keep accumulating the oocytes after doing ICSI, so to get more number of euploid blastocysts for transfer. And always prognosticate the patient. That is important. Thank you, sir. Thanks for the patient listening.
Thank you, Dr. Nidhi Sharma. Thank you.
Thank you.
Moving ahead, I would like to introduce our next speaker, Dr. Nikhil Shetty, Professor and Unit Head, Department of Obstetrics and Gynecology, Kasturiba Medical College, Bangalore, India, who would be speaking on the topic cost effectiveness in controlled ovarian stimulation.
Good evening, ladies and gentlemen. It gives me great pleasure to be part of this 13th edition of the Merck Foundation Africa Asia Luminary. I would like to thank Merck Foundation for giving me this opportunity to be here part with all of you today. We were postulated to meet in Mumbai. Unfortunately, due to global instances, we are meeting here online. I'm hoping that we get the future to meet each other and network in the future. So, brief introduction who I am. My name is Dr. Nikhil Shetty. I'm a professor in the Department of Obstetrics and Gynecology, KMC Mangalore, a constant unit of Mahim Manipal. I'm also the unit head, clinical head, and consultant IVF specialist of Ankur Fertility, Mangalore. I'm here to talk about a very important topic for me, that is cost effectiveness of controlled ovarian stimulation. Cost has been a big detrimental factor in IVF, especially in low and middle income countries. As all infertility specialists know, the incidence of IVF and incidence of infertility per se has been increasing over the years. And the WHO has postulated that 1 in 6 people suffer from infertility at some stage of their life, with a lifetime risk about 17.5%. Unfortunately, for most people or most couples, IVF, most of them will end up in IVF. And IVF is a very costly affair for couples. It is not just the direct medical costs that are associated with it, but there are also a lot of hidden costs for which the couple, when they undergo IVF treatments. The IVF industry in India is valued anywhere between $0.8 to $1.2 billion, and it is expected to grow at an exponential rate, reaching about $3,400 billion by the year of 2030, 2035. To really understand the cost of IVF, we'll look at the higher income countries. And this is an article that was published in 2023. It evaluated the cost leading to a live birth rate from one fresh transfer. And the cost for various countries like Spain, Norway, UK, Germany, Denmark, South Korea, Australia, New York, it was anywhere between 8,000 euros to 12,400 euros. When looking at the financial costs associated with ART for patients in low and middle income countries, a systematic review was highlighted here, which was published in the year of 2023, where it looked in the cost of ART in lower and middle income countries. For the African region, it was approximately in US dollars about $2,200 up to about 10,000 US dollars. And in Southeast Asian regions, it was anywhere between $2,000 to about 18 to 20,000 US dollars. This study also tried to look into the direct medical costs as well as the non-medical costs. Unfortunately, some of the regions did not have this data, but it kind of gave an idea about how problematic it was for couples. Another very, very important point that was highlighted by this article was that the direct medical costs paid by the patients are often higher than the GDP per capita, making it unaffordable for most people in that particular region. Therefore, IVF actually is quite expensive, especially in low and middle income countries. Now, looking at IVF, who actually pays the cost of this IVF? There are only two scenarios. One is the most common to us, wherein the patients themselves pay the money out of their own pockets. Because in our low and middle income countries, the government does not pay for the IVF, or we don't have any insurance policy for IVF. The other set of group is, let's say, in the higher middle income countries, it's the government actually could pay for the IVF, and insurance policies are there which cover the IVF. But in our countries, ART is generally not financed by the government. It's largely unregulated and it's omitted from government policies. Therefore, this potentially plays a role in limiting the coverage of insurance. Now, with the advent of the ART regulation bill, which has recently come out, we're hoping that in India we'll be able to get government policies, and hopefully it'll come under the ambit of insurance. So when you look at IVF per se or any of the ART procedures, what are we trying to do? What is the principle of the ART? In the principle, we are basically trying to use technology to the best out of the couple so that they achieve their goal, and that is a live, born, healthy child. Now, unfortunately, this costs a lot of money, depending on the scenario, depending on the comorbidities, depending on the couple per se. So I would like to highlight a paper which is published in the Human Reproduction Open in 2022. This was basically the data from the European IVF Monitoring Consortium, which looked into about 11 million treatment cycles and birth of over around 2 million infants from the year about 1997 all the way to 2018. And here, the two things that I would like to highlight is that the pregnancy rate per aspiration initially increased and then gradually tapered down. And if you look at the delivery rate per aspiration, it's kind of plateaued itself, which is a little surprising when you look at IVF or ART and the progress it has made over the years. It is one of the rapidly progressing fields, and including nowadays with advent of AI, we are expecting the pregnancy rate to improve. So what could answer this question as why this is dropping down? It could be because of the patient profile right now, the ovarian reserves, the sperm parameters that we're dealing with right now, which could be affecting it. So because of these changes in these things, we are likely to use more technology and use more different adjuvants that are there in order for us to get that successful pregnancy. And therefore, they will increase the cost of the treatment. So when you look at cost of IVF, what all does this IVF cost include? It includes everything from screening from the ART treatment, the ovarian stimulation, all the way down to pregnancy. And this has been quite effectively studied in literature. So when looking at it individually, what are the costs of screening prior to ART? The cost of screening could be either with the blood test that we do prior to the ART, the ovarian reserve testing, the advanced semen analysis. If we decide to do a hysteroscopy prior to an IVF, which was done routinely previously, which is now coming out of vogue. Even the endometrial scratch, that was an adjuvant that came, which was quite successful initially, was kind of abandoned in between, now slowly creeping back, and has some benefits in certain amount of patients. And the adjuvant medicines and treatments like DHEA, or we're talking about coenzyme Q10, can all increase the cost of treatment. The main cost in IVF treatment comes from the procedural cost, and in the procedural cost, it is the control ovarian stimulation and the monitoring that has the majority of the cost, which is about 30 to 50% of the total cost of the patient. And this is what my main talk is about today. The other costs can come from the oocyte retrieval, whether we're using GA, are we using sedations, are we using local, whether you're planning to do IVF or ICSI, the cost can vary. If you're planning to do pre-implantation genetic diagnosis, then yes, definitely that will cost will increase. Assisted hatching. If you're doing a fresh transfer, the cost will be relatively lesser. If you're doing a frozen embryo transfer, cost is likely to be higher. And the luteal phase support. All of them have an impact on costs. When you look at pregnancies, the costs depend upon mainly whether it is a singleton pregnancy or whether it is a multiple pregnancies. If that pregnancy ends up resulting in an abortion or a miscarriage, then the patient has lost most of their money. If the mother develops some comorbid conditions in pregnancy or medical disorders such as preeclampsia or gestation diabetes, they will increase the financial cost related to ART. They could have preterm deliveries where the baby will deliver much earlier, or since most of these patients who undergo ART are likely to end up in a cesarean section, that all can increase the cost. What are the patient-related costs that we don't really talk too much about is when patients come for treatment to IVF or ART for whatever treatment they're coming for, they may not be from the same area that they're coming from. they might have to travel, and therefore their travel and their accommodation costs will need to be looked into. The multiple visits that you need to come to the clinic can cost them a lot. And more importantly, because if they're in the clinic or they move somewhere else, they're not working there, so they need to take leave, they might have to take loss of pay. And especially if they're working, not working, if they're in a family wherein they have either a previous child or they have an elderly parent, leaving them alone and coming from a different place makes it difficult for them. So may have to hire someone to look after their children or their parents. They all are costs for patients. So coming to the main topic that I'm discussing today is the role of control ovarian stimulation in IVF especially, and try to understand its cost effectiveness. IVF is financially demanding for many couples. The medication contributes to about 30 to 50% of the cycle cost. Poor responders and OHSs can definitely increase the expenditure, and the goal of control ovarian stimulation is to maximize live birth cycle. But at what cost? That is the whole question. So what are the key cost drivers of COS that we're dealing with right now? So the most important thing is to do with the gonadotropin. The gonadotropin type, the gonadotropin dose, and the duration of gonadotropins all have an impact on cost. The protocol that we're choosing also can be affected whether using antagonists or we're using agonists or any other type of protocol. The monitoring, its visits, and its investigations related have an impact on finances. If we end up doing the treatment and we don't continue the treatment and we have to stop the treatment in any way, for example, there is no follicle growing, the cycle cancellation, the patients who are not under insurance will have to bear the cost of that failed cycle. And most important thing that can impact costs is OHSS. Now, OHSS, if the patient develops it, they will have increased costs, they will need hospitalization, they might even require ICU admissions. Therefore, the cost of the treatment drastically increases. So what are the principles of cost effectiveness in control ovarian stimulation? The first thing is to individualize the treatment rather than standardize the treatment that do not follow everybody under the same protocol with the same standard gonadotropin dose. Individualize the patients. One, avoid overstimulation, because the concept is, yes, if you have the more number of oocytes and you have more number of embryos, then the better chance of a pregnancy. But we need to be very careful about how much we're going to stimulate. Optimize the first cycle success as much as possible and minimize complication, especially OHSS, and also try to prevent dropouts. So in the customization, is most important is individualization. Now for individualization, the parameters that are very, very detrimental for us to individualize our treatment is the age of the patient. One of the most important factors that tell us the impact of our control ovarian stimulation or the pregnancy for that matter would be age. Age less than 35 is okay, age more than 35 is likely to be an issue. Patients who have ovarian reserves, that is the AMH and the AFC, which depicts the ovarian reserve. Patients with lesser ovarian reserve need a different type of treatment. Patients with normal ovarian reserve might require a different type of treatment. BMI has an impact on our individualization, and previous stimulation response helps us decide what type of dose, what type of gonadotropin, and what type of protocol we need to do. So therefore, what we're expecting are three scenarios from this individualization. Either we're getting a hyper response, that is in PMS patients who are prone to OHSS, that's what we don't want, or we can get a normal response, that is what we all hope for, that is adequate ovarian reserve markers and normal response to ovarian stimulation, or we get a very poor ovarian response, and that poor ovarian response is usually classified by Poseidon. And in Poseidon, there are 4 categories that most of you already know, but individualization needs to look into, because some of the groups may require milder stimulation, some may require higher doses of gonadotropins. Younger ones with low ovarian reserve are likely to have a successful pregnancy. Milder stimulation might help them a lot compared to giving them overstimulation. Some of them may require more than one cycle of control ovarian stimulation, especially when you're dealing with poor ovarian reserve, and that also needs looked into and discussed when we talk about cost effectiveness. The second thing in cost effectiveness, other than the gonadotropin, was the protocol that we follow. If you look at the protocols, the most common protocols is the agonist protocol, the long protocol, and the antagonist protocol. Both of them have similar outcomes, but generous antagonists can be cost effective. And the cost effectiveness is purely by the first point, that is, it reduces OHS's risk. Okay, mainly because we can give an agonist trigger. Because it reduces the OHS risk, it becomes very more cost effective, because I told you OHSs can increase the cost of the treatment drastically. The second thing is gonadotropin total dose can be slightly lesser, because the down regulation is lesser in a patient who is in an antagonist protocol. Instead of an antagonist, we could even use progesterone primed ovarian stimulation, which could reduce the cost further. The duration of the treatment is shorter in an antagonist protocol, so therefore patients who are flying from other places who need to shift for the treatments, the time duration that they need to spend is much shorter. And if we use flexible protocols rather than fixed protocols, then we can actually make it more cost effective. So looking at the gonadotropin per se, in gonadotropins, what most of us will likely to use is the recombinant FSH, and mainly because of its consistent batch quality, the more number of oocytes you're likely to get, the more oocytes, the more embryos, and it's easier subcutaneous route. The problem with recombinant FSH is the higher cost and the higher chances of OHSs. Both of them can increase the cost for the IVF cycle. Other option is to do urinary HMG. Both FSH and urinary HMG are quite equal to each other and can be used. They have a lower medical cost. They may even improve oocyte competence, and they have a lower OHSS rate, which can make it more cost effective. Urinary FSH not so used so much in modern ART. They're cheaper, but they have a lot of batch variability and it's a little unreliable. And we're also likely to use higher doses with them. What about using recombinant LH? So this is a paper showing the cost-effective analysis of COS using recombinant FSH with HMG with people undergoing IVF. In that, it showed a higher cost-effectiveness for recombinant LH addition than HMG in 2-year observation. So basically, the cost of adding recombinant LH into the treatment cycle will increase the medication cost, but adding FSH and LH can make it more cost-effective by increasing the pregnancy rate. So increasing the pregnancy rate, that means the faster duration to pregnancy, less number of cycles, they're likely to make it more cost effective, even though the total dose, the total cost of the treatment can be higher. When looking at the different types of gonadotropins, that is between alpha and delta, I don't have too much experience using delta, I'm more using alpha. But delta is known to produce more oocytes rather than alpha, and the greatest advantage of delta is because the dose is calculated based on AMH and body weight, and therefore it reduces the chances of OHSS, and that point itself can make it more cost effective actually, based on the publications that are presented here. So when we're doing minimal stimulation protocols, even adding letrozole or clomiphene citrate can help out a lot and make it more cost effective, because it lowers the gonadotropin consumption, reduces the monitoring burden, it lowers the incidence of OHSS, which is the boon in all of this, and it's especially useful in poor responders and very cost effective settings. But the biggest problem with adding this is we need to be very realistic, and we need to counsel the patients regarding the oocyte yield and also possibilities of cancelled cycles. Just to brush through the ESHRE guidelines related to the gonadotropins, first is between recombinant FSH and HMG. Both of them are equally recommended with very, very strong recommendations. Looking at recombinant LH addition in the general IVF population, in low responders or even patients more than age of 35, both of them are recommended, that is just FSH or even adding LH to it under conditional evidence. And in terms of between the type of FSH, that is alpha and beta, both and delta, both are equally recommended for ovarian stimulation. But yes, delta could have an edge basically because of the reduction in the OHSS incidence. So that is to do with the individualization of the gonadotropin and the gonadotropin protocols. The second place that we can help out and reduce and make it more cost effective is optimizing monitoring. Now, the monitoring needs to be individualized. It needs to be based on the protocol that we are following, and we need to avoid excessive hormonal testing. We might need to do strategic ultrasound scheduling depending on the stimulation protocol. If we're using low dose gonadotropins, or in case we're using letrozole or clomiphene citrate, maybe we could cater or tinker at monitoring a little bit. Using teleconsultation for counseling and follow-up can also be quite useful and reducing the costs. As I've been mentioning from the beginning of my talk, prevention of OHSS saves cost. And the prevention is based on the OHSS free clinic, and has 3 prongs, that is prevention, prediction, and early detection. So these things require a risk assessment before stimulation, identifying the group of women who are likely to hyper respond. Using an antagonist cycle in high responders makes more sense because of the agonist trigger, and giving them a GnRH agonist trigger can reduce the incidence of HSS, and a freeze-all strategy when required can reduce the incidence of HSS. So what will this do? It will avoid hospitalization and especially ICU expenditure, and therefore make it more cost effective. As we all know, there's a lot of adjuvants that we can use in ART. It could be for the oocyte, it could be for the sperm, it could be for the embryo, it could be for the endometrium, or there could be other alternative therapies. the various things that in the market, they have come in, they have been in favor, gone out of favor. And what we need to understand is we need to justify its use. There is limited evidence for the routine use of any of these adjuvants. Growth hormone, PRP, and supplements increase the cost. And in case there are certain selective situations, let's say we're dealing with a decreased endometrial thickness, maybe we could use it for a specific benefit. And where we do not have any benefit, avoid empirical add-ons is the dictum. To conclude, cost effectiveness in an IVF or a controlled ovarian stimulation basically is maximizing the live birth while minimizing avoidable cost. And that basically is by individualization of the gonadotropin, the type of gonadotropin, and even the protocol that we're planning on doing, and individualization based on the patient profile, that is the age, the AMH, the AFC, the BMI, and how they responded previously, deciding whether you're dealing with a poor responder or an high responder. Adding letrozole or clomiphene citrate to in minimal stimulations could make it more effective. And the most important thing is prevention of OHSS. And having an OHSS-free clinic can make the IVF cycle more cost-effective. And in terms of adjuvants, evidence-based practice prevents unnecessary expenditure, and that is very, very important in terms of adjuvants. Therefore, we're trying to make IVF affordable, basically improves the accessibility to IVF even in low and middle income countries, and the compliance. And therefore, if the patient does not work out the first cycle, the patient should be able to come back again for a next cycle. And therefore, it is very, very important that we try to make the IVF cycle cost effective with the goal of getting a live birth rate without trying to increase the cost of the IVF treatment. So therefore, this is my small talk, which I've given to you all today. I'm hoping that you enjoyed it. If there's anything that I could help you out with, please contact me. And I would like to thank Merck again for this opportunity. I'm hoping to meet you all in the future. Thank you. Thank you so much for the opportunity to interact with all of you all here today. It's one of the duties for all of us as IVF specialists, especially when we work in low and middle income countries, for that matter, is to improve the cost effectiveness. But when we're trying to concentrate a lot on the cost effectiveness, it's important that we do not forget about making sure our goal, that is, make sure that the patient gets a normal, healthy life child. So there are various ways to look into it. Certain aspects I've not touched upon is like what Dr. Nidhi had just spoken about, the dual stimulation. That also could help out a lot. And now with the role of AI coming into the picture, as we heard the beautiful talk previous to this, it could improve pregnancy rates and hopefully make it more and more cost effective. Thank you.
Thank you, Dr. Nikhil Shetty, for that amazing presentation. And moving forward, next we shall have a presentation on the topic Best Approaches to the Postpartum Depression and Postpartum Psychosis. That has been co-presented by Professor Tayyab Tahir, Consultant Liaison Psychiatrist, Department of Liaison Psychiatry, University Hospitals of Wales, Cardiff, UK, and Chukwemeka Esgwi, Senior Trainee, Department of General Psychiatry, University Hospitals of Wales, Cardiff, UK.
Thank you for inviting us. This is the third time that I am presenting at this prestigious event. We're going to talk about the best approaches to postpartum depression and postpartum psychosis. The aim is to briefly introduce the interface between liaison psychiatry and perinatal psychiatry. We both work in liaison psychiatry but have an interest in perinatal psychiatry. In particular, Dr. Ezegi is going to talk about perinatal mental health disorders and some general management advice. This is a paper that is very, very important. I read it many years ago, and it says there's no health without mental health. This is a key document for developing liaison psychiatry services because it talks about reorganization of services in general hospital setting and also introducing training and education underpinning the need for mental health disorders to be identified and engaging patients and carers. At the same time, this document, an editorial was written by the president of the Royal College of Psychiatrists at that time, Professor Kendall, and he concluded this editorial by saying that if we use mental and physical illnesses as terms, we should preface by saying so-called, and these are archaic terms and deeply misleading terms. I took this picture many years ago, and I felt that those who work in liaison psychiatry in general, or psychiatry, they face a number of challenges. And if you're a patient, you face a lot of stigma. And if you have comorbid physical health disorders, then it is important to bridge the gap between physical and mental health. And sometimes patients do not trust their doctors for managing their emotional problems. Hence, some work was done by the Royal College of Psychiatrists in Wales, where it was important to identify person-centered biopsychosocial approach with 4 pillars of establishing trust, having a good communication, empathy, and establishing respect and dignity, where we as doctors in general and psychiatrists in particular, or those who work in health profession, for us to work as leaders within our teams and beyond our teams, and be transparent and accountable, but importantly to co-produce care plans and policies working alongside service users and carers. Why liaison psychiatry is important? Let me just pre-warn you to get your cameras ready, because in the next slide there would be a QR code for you to take down a paper and read it in your own time. It would just save some time for this presentation. Liaison psychiatry is important because it's the first port of call at times when people present to emergency services or in general hospital for their physical health problems. We reduce excess morbidity associated with comorbidity, and consequently we do have an impact on mortality associated with morbidity, and the number of presentations that we deal with are related to self-harm. But importantly, a lot of our work is about reducing stigma. Please take this QR code for an editorial that I had recently written with a couple of my colleagues. It talks about liaison psychiatry and the interface with maternity services. Health is not equally distributed, and we know about that. And when it comes to women, it is even more important to consider ensuring parity of esteem. We deal with a number of presentations which include psychological reactions to physical illnesses, organic causes of common psychiatric symptoms, unexplained medical symptoms, capacity assessment, which is everybody's business, not just psychiatrists. And I've already mentioned about deliberate self-harm and suicide. We have 2 roles, one as a consultation psychiatrist and then the liaison psychiatrist. We can give an opinion and hand over the care to the team, and that's the consultation role. But as a liaison psychiatrist, we become part and parcel of medical and surgical teams. Keep your cameras ready for another QR code. This is a paper that I had written on reducing the duration of untreated illnesses. And in certain cultures or subcultures, it's important to consider bio-psycho-social spiritual model to help understand psychiatric symptoms and consequently bridge the gap between mental health and spirituality by collaborating with others beyond the health profession. It's important to explore everyday experiences, illness beliefs, and patients' concerns and expectations, and a 4P model of predisposing, precipitating, protective factors and perpetuating factors along with iatrogenicity is important on a bio-psychosocial grid, and this information can then be used to draw a management plan for a short term, medium term, and long term. management plan. I'm going to hand over to my colleague to talk about perinatal mental health, and this is the core part of this talk, and hopefully the introduction to liaison psychiatry would help you understand the interface between perinatal mental health and liaison psychiatry.
Thank you very much, Professor Tahir. As you mentioned, my name is Dr. Meka Zigwe. I'm a registrar working with Professor Tahir in the Department of Liaison Psychiatry. Now, perinatal mental health refers to psychiatric conditions that are present during pregnancy and in the perinatal period. Now, there is no established consensus as to what constitutes the perinatal period, or rather the postnatal period, but in general, most agree that it includes up to the first year after birth. More and more, there's development of specialist perinatal mental health teams to provide expert advice and treatment to women and families within the postnatal period or the perinatal period, because we realize that outcomes here are incredibly important, both to the mother but also to the child, as we know more and more that many mental health conditions have their roots in early childhood experiences. Therefore, interventions here can have massive outcomes. Now, the psychosocial stresses which manifest in difficulties with mental health in the perinatal period are the same just like other periods. However, these stresses can be felt far more acutely within the perinatal period. For example, some factors such as domestic abuse are far more pertinent in the perinatal period, because we know that unfortunately incidents of domestic abuse can begin or escalate during this time. Also, things like poor housing, poverty, and a lack of support can be felt far more acutely in the perinatal period compared to other periods of life. So overall, we know that mental health conditions can be a result of a complication of physical health. They can affect the whole family, they contribute to mortality, and they can lead to unfavorable outcomes for newborns, infants, and children. In the UK, there is a long history of confidential inquiries which have looked into maternal death. They've acquired data since the 1950s, and they've specifically collected psychiatric data for the last 35 years. Embrace is a collaborative research program responsible for investigating maternal deaths, with the main goal of identifying causes of death and recommending improvements in maternity care in order to prevent future death. In their documentation published in 2024, they found that maternal suicide was the fourth most common direct cause of a woman's death up to 6 weeks after pregnancy, and between 6 weeks and 1 year post-pregnancy, it was a leading cause of maternal death. Now, actually, in the perinatal period, the risk of suicide is reduced compared to other periods of a woman's life. But at the same time, for a woman who experiences mental illness, especially those who experience serious mental illness, their risk of suicide is increased over and above other women. And women who have been admitted to a psychiatric unit within the first postnatal year have a significantly increased risk of suicide. The confidential inquiry for maternal death, so this is CEMED, they gave the following red flag symptoms for suicide in a perinatal period. And these are a recent significant change in mental state or emergence of new symptoms, new thoughts or acts of violent self-harm, and or new persistent expressions of incompetence as a mother or estrangement from the infant. So these are things that when we assess these women, we should be looking out for. And if they're present, these women should be considered as being high risk and are necessary to have further assessment. There are a range of perinatal disorders, but it's important to note that a woman can experience comorbid conditions prior to pregnancy, which can then continue into pregnancy and can affect the pregnancy. But for the rest of this talk, we'll focus predominantly on postpartum mood changes. So these are postpartum depression and postpartum psychosis. So mood changes and mood swings are extremely common and are often normal following childbirth. The baby blues describes a brief period of low mood, tearfulness, and emotional lability. And this is experienced by the vast majority of new mothers, so up to 75% of new mothers. The classic presentation is that it starts within 2 to 3 days after childbirth, and it usually ends by the 5th day and certainly resolves within the first 10 days. And it's thought that this might be related to dips in certain hormones such as progesterone, estrogen, as well as changes in prolactin. If symptoms are ongoing beyond 2 weeks, these women need further assessment, as this could actually represent postpartum depression. So this is a depressive episode, typically within the first 6 months postnatally. It's found in 10 to 15% of new mothers, and it can range from mild to severe in severity. Importantly, it's associated with increased risk of suicide, and it can have lasting impacts on the parent-infant relationship, which, as I mentioned before, can have an effect on that child's risk for developing mental problems in their later life. It's more common in women who've had multiple children, and in 30% of cases, depression actually started during pregnancy and continued into the postpartum period. Postpartum psychosis describes a very serious and rapidly evolving form of manic schizophrenic-informed psychosis. These patients can present with prominent mood symptoms, as well as other psychotic symptoms like hallucinations, delusions, a misinterpretation of perceptions. They can be very perplexed and appear very confused. And especially in the early stages, this can resemble a delirium before the more classical psychotic symptoms emerge. It constitutes a psychiatric emergency due to its rapidly evolving nature. A woman can present from completely well to being floridly psychotic within a matter of hours. It is found in 1 to 2 per 1,000 births, and it is most common in first pregnancies. The onset is typically 3 to 10 days after delivery, but it can happen much more quickly in some women. For example, women with bipolar disorder, it can happen during pregnancy or immediately after birth. It's associated with increased risk of suicide, and importantly, infanticidal thoughts are found in 8% of women with postpartum psychosis, so there's also a risk to the child. With regards to postpartum depression, the greatest risk factor is a positive previous history of depression or postpartum depression if there have been previous pregnancies. It's more common in younger mothers, especially if they're under the age of 25, and in mothers who've had multiple pregnancies. And it's important to note also that in a third of the cases, the depression starts during pregnancy. With postpartum psychosis, again, the strongest risk factor is a positive previous history of postpartum psychosis or a history of bipolar disorder type 1 or a positive family history. Now, this table describes the risk relative for women of developing postpartum psychosis, and it shows that for women with no history of mental illness and no immediate family history of postpartum psychosis, their risk is 1 to 2 in 1,000. For women with bipolar type 1 or schizoaffective disorder having their first pregnancy, their risk of developing postpartum psychosis is 1 in 5. If a woman has a previous history of postpartum psychosis, her risk of developing it with each subsequent pregnancy is 50%. As Professor Tahir mentioned previously, the management for these conditions should all follow a biopsychosocial model. If there's a pre-existing mental health disorder, you should treat that as normal. For postpartum blues or baby blues, these can settle with just supportive treatment. For postpartum depression, medication might be required in moderate to severe cases, and for postpartum psychosis, this usually requires inpatient care, antipsychotics, and sometimes electroconvulsive therapy if there's minimal or no response to these treatments. There are lots of things that we should consider when thinking about prescribing in the perinatal period. We should think about the woman's previous response, the severity of illness and the presentation, and the values and priorities for the mother. And we must always balance the risk related to medication and untreated illness. We therefore need to find a balance between risks from medication, risks of untreated illness, and the benefits of treating with medication. So when we think about prescribing medication, we need to make sure that it is appropriate for the mother. If it's overly sedating and she's a primary carer, it might not be the right medication for her, for example. If she's breastfeeding and it's not appropriate for breastfeeding, this might not be the right medication for her. If she's pregnant and it is teratogenic, for example, sodium valproate, this is absolutely not appropriate for her. But there's also risks of not treating. The woman might relapse, require hospital, might attempt suicide. There's impacts on poor mental health disorders for the mother on the infant, which can affect them in later life. It could impair her wider relationships. It could impair her ability to parent. And then there's the benefits of treating. We can avoid relapse and reduce suicide risk. We can support the mother and infant's bonding. We can make sure the fetal well-being is protected, and we can make sure that the woman remains well. So this is quite a busy slide, but it just outlines some of the principles of prescribing in the perinatal period. One thing I would just like to summarize is that in many cases, antidepressants can be used in the perinatal period. Many of them are safe in pregnancy. Sertraline in particular has good evidence. With regards to mood stabilizers, valproate must be avoided throughout the entire pregnancy due to the significant risk of congenital malformations. Therefore, if a woman is on valproate for a mental health condition and she becomes pregnant, this must be stopped by the consultant psychiatrist, and the alternatives can be trialed. Antipsychotics like olanzapine and quetiapine are used widely during pregnancy and the postnatal period. But again, we need to be logical and pragmatic in terms of our prescribing. So to summarize, multidisciplinary team working can contribute to healthier pregnancies, can reduce the risk of postpartum mental health issues, and can ultimately positively impact on the well-being of both the mother and the child. Early identification of symptoms is crucial as it's linking into the appropriate treatment pathway. And some psychotropic medications can be used with care and considerate prescribing in the perinatal period. I'll hand you back over to Professor Tahir.
Thank you very much, Emeka. It's fascinating to hear information from yourself. But the important point is to think in terms of increased remission rates and gradually moving through the steps of preventing relapses, restoring physical functioning, and restoring social functioning. And that can be achieved through collaborative care with the patients and their carers, and also with those who are providing care. The general principles are ensuring patient and family are involved, staff looking after the patients, they are involved, and there's a communication between mental health services and the patient, family, and staff. But treatments should be evidence-based. It's important to think of all the important factors that Dr. Ezekiel has mentioned. And thinking in terms of management plan, here's an example of short-term, medium-term, and long-term management plan. These slides could be made available for you to go through those integral parts of management. In general, it should be an integrated approach to emotional and psychiatric health. Focus should be to reduce burden of treatment and ensuring that appropriate psychological treatments are also considered. For moderate to severe symptoms of psychiatric nature, pharmacotherapy should be used, and that amazing slide that was shared in terms of balance between risk and benefits should be considered. I've already shared this paper with you, and you can read the important areas that we have been discussing. In general, 10 important things for all general hospital staff should be part of your education program, which helps identify patients who need more specialist help. In summary, there's no health without mental health, and mental health is everybody's business, and mental health concerns can arise from subtle disruptions in normal psychological mechanisms that produce distortions in bodily consciousness and control, and more so in perinatal mental health. We will stop here, and thank you for listening.
Yeah, we thank you, Professor Dr. Tahir and Dr. Esigwe for that insightful discussion. Please have some thoughts and share your words. Thank you.
First of all, I would like to thank you, Dr. Shadab and Merck Foundation for inviting me again. And I'm very grateful for Dr. Esigwe to contribute to this presentation. It's a very tricky subject to deal with because these are sensitive issues, and stigma is a huge, huge burden that people carry, and especially in certain cultures. Although not directly related, I still put that slide up for the paper I had written in terms of spirituality and bridging the gap, because those are the issues. Sometimes they act as barriers.
Thank you so much, Professor Tahir. And thank you so much, Dr. Esigwe, for joining us today, for the wonderful presentation shared by all, and also for the insights that you all have shared with us.
Moving forward, I would now like to share the video presentation by our final speaker for the day, Dr. Priya Vansia, Program Director for Postgraduate Certificate in Sexual Health Medicine, University of South Wales, UK.
Hello, my name is Dr. Priya Vansia. Thank you very much for this opportunity to speak today. I'll be talking about menopause hormone therapy and the myths and reality about it. These are some of the aims I'm going to try and cover on our very quick presentation today, and I'll be doing that by going through a few very common views or statements that I hear in my practice and thinking about whether they are myth or reality. So number one, the menopause is a natural stage of a woman's reproductive life, so it doesn't need treatment. And I hear this from women, men, healthcare professionals, the public. And the easiest way I find to tackle this perception is that pregnancy and labour is also a natural stage of a woman's reproductive life, but it doesn't mean that we don't intervene or provide treatment to reduce morbidity or mortality. So unfortunately, a lot of the research behind MHT is done on white European, American and British women. And what we find in the UK is that women from non-white backgrounds are much less likely to seek or access MHT. And some research looking into this found that it was often due to different cultural beliefs and attitudes around the menopause, which are on the screen. So for example, every woman goes through it, so what's the big issue? And symptoms tend to be minimised. A lack of awareness and education about what is actually happening in their own body during the menopause. Stigma, perhaps because it represents a loss of fertility or femininity, but actually compared to white women, there tends to be a bigger acceptance of aging in some Black and Asian communities. And then there's this expectation to just get on with it. In a lot of countries and a lot of cultures, seeking medical help is not easy and is not an option. So people just get on with it. So to really understand why menopause may need treatment, it's important to understand some basic physiology around it. So in a female embryo, at the time of about 7 months gestation, there are about 7 million oocytes or eggs. And these actually naturally deplete at an exponential rate. So by the time of birth, we actually only have 1 million oocytes. Then by the time menarche occurs, so the first period, we have about 400,000. And what happens then at each menstrual cycle, about 20 follicles are sort of recruited, and each of these follicles contains one oocyte or one egg. And one of these eggs will be released at ovulation. And on top of that, we have a natural decline of our follicles as well. So very simply, as we get towards the end of our reproductive life, women have less follicles and they become less responsive to gonadotrophins, so these chemicals from the anterior pituitary that produce or promote the production of estrogen from the follicles. So the production of estrogen from our ovaries becomes both low and erratic, and this is what causes our menstruation to become irregular. So actually the definition of menopause is when a woman has not had menstruation naturally for over 12 months, and it marks the end of reproductive life. It's a retrospective diagnosis, and around this time we only have about 100 or less than 100 oocytes. And the estrogen is very low, so there's no release of an egg, no ovulation, no pregnancy risk, and there's no menstruation. A loss of ovarian function can also occur in other ways. So for example, a surgical menopause would be post-oophorectomy, so post-removal of both ovaries, because there's no release of any estrogen. Or we can have iatrogenic menopause, so when it's been caused by treatments such as chemotherapy or other drugs as well. So in the UK, the average white British woman reaches the menopause at around age 51, but there's been some studies in the UK to look at different races and ethnicities, and they found that the average age for Black, African and Caribbean women was 49.6, so not too dissimilar, but in South Asian women it's thought to be younger, so 46.7. So it's really useful to know this when you are thinking about menopause and who your population is, and obviously it will be very different for you, perhaps to ours here in the UK. We here define an early menopause as under the age of 45, but for example in Asian women this might not be appropriate, might not be early at all, and we just define premature ovarian insufficiency as under the age of 40. So if this is a natural stage in a woman's life, then why does it need treatment? Well, obviously estrogen plays an important role in the reproductive cycle, but estrogen receptors are found all over the body, including cardiovascular system, brain and bones. And it is the decline and the fluctuation of estrogen on these systems that cause symptoms of the menopause. And these are outlined on the chart on the left. And these symptoms actually, rather than starting at the menopause, so when you finish your menstruation, they start in the years before when estrogen starts to decline. And this is known as the perimenopause or the menopause transition. And there was one large UK survey that actually found that 80 to 90% of women experience menopause symptoms of some sort, and about a third of these women think that the symptoms are severe, and so severe that they're affecting their quality of life. So if you look on the chart on the left, there are a really big range of symptoms, and we can categorize these. And perhaps vasomotor symptoms are the ones that we're commonly aware of, so hot flushes. But what we commonly see in the UK is actually psychological issues. So things like anxiety, mood. We often meet quite high functioning women with big jobs who suddenly realize that they can't find the words, or they struggle to do basic things that they used to, and they call it sort of brain fog. So this sort of impaired memory and concentration. And this is often diagnosed or misdiagnosed, as sort of mental health problems, and women are often started on antidepressants. Urogenital symptoms are really, really common, and they're often underreported due to embarrassment, and often because clinicians don't ask. But things like sore vulval vaginal dryness, recurrent UTIs, and actually 51% of women in this survey said that the menopause symptoms affected their sex life. So this will be a combination of the urogenital symptoms, the mood symptoms, vasomotor symptoms, everything. But it has a profound effect on women. And there's lots of other things as well. For example, headaches can increase, and joint pain and stiffness. What's also important to know is that it can affect women of different ethnic backgrounds very differently. And there was a really large study done in the US with over 60,000 women, and they really identified these differences. And so, for example, in Black women, they found that the vasomotor symptoms were much more common and much more prolonged. So knowing this variation is really important. So we're aware of the breadth of menopause symptoms and think about what patterns of symptoms are likely to be prevalent in your population. And it's also, I'm very sorry to use sort of UK-based stats all the time, but it's important to realise that this isn't just a woman's individual issue. It can have much larger consequences. So in the UK, 4 million women are aged 50 to 64 at work. And this can have a profound effect because one survey found that 3 out of 5 women experiencing menopause said it negatively affected their work. So it's not just an individual problem. So MHT can help, and actually in the UK we call MHT HRT, so hormone replacement therapy, and that's basically because we are replacing the estrogen that is declining in our body with exogenous estrogen, and that can really help relieve symptoms. And the exogenous estrogen can be in the form of tablets, gels, patches or sprays, so either orally or transdermally. Women who have a uterus, so they haven't had a hysterectomy, will always need progesterone alongside their estrogen. The progesterone is not part of the treatment, really. It's not part of the symptomatic relief, but it is needed because without it, estrogen can thicken the lining of the womb and predispose women to what we call endometrial hyperplasia and possibly endometrial cancer. So progesterone alongside is really necessary, and progesterone can be either in the form of a tablet, patches, or also intrauterine systems or coils. Estrogen and progesterone can be taken separately, or you can actually have them in combined preparations before. And sort of it's beyond the scope of today, obviously, to go into details about how to prescribe, but it really depends on what's available to you, what your resources are, what suits the patient, and what they're actually going to comply with. And obviously what is safest, and we'll talk a little bit about that later. Really importantly is that vaginal estrogen is recommended to all women with urogenital symptoms, and we won't know if they have urogenital symptoms unless we ask them. So are they dry down below? Do they have itching? Is sex painful? Is there bleeding, that we don't know about perhaps on wiping? And that all needs to be investigated. And vaginal estrogen often comes in creams or pessaries, a little bit messy to use, often used at night, but you can use that on top of systemic MHT, and that often really helps urogenital symptoms, and that's definitely something I would recommend thinking about. Another important consideration of the benefit of starting MHT in women is the long-term benefits, and unlike the relief of symptoms, these things can't be quantified or felt by women, so it's important that as healthcare professionals we are aware of them and we advise our patients about them. We all know that cardiovascular disease is the global cause of mortality, so actually estrogen is protective of cardiovascular disease. It reduces atheroma formation, and there have been numerous studies, including the ELITE study and KEEP study, that have consistently showed early initiation of MHT within 10 years of the menopause can have cardiovascular benefit by reducing atheroma progression and improving vascular function. The protective benefit becomes a little less clear with late initiation, particularly above the age of 60, and some studies suggest there's actually an increased risk in this later initiation, such as stroke, but they highlight the importance of this window of opportunity in the early stages to gain these cardioprotective benefits. Estrogen also reduces osteoclast activity and possibly stimulates osteoblast activity, so increases bone formation. So during the menopause, as our estrogen decreases, our bone density increases, putting women at risk of fragility fractures. MHT can actually reduce this risk, and the British Menopause Society actually recommend using MHT as first-line therapy for women under 60 with osteoporosis, and no other risk factors that contraindicate the MHT. There's also lots of ongoing research about the effect of menopause on the brain and whether or not MHT can reduce cognitive decline. So the cardiovascular benefits in early stages is clear, as is the bone benefits, and there's still a lot of research into other things as well. So I hope I've given you some things to think about in terms of why the menopause may need treatment in some women. Menopause hormone therapy is not suitable for women with cardiac or venous thromboembolism risk factors or disease. So we know that MHT can reduce the cardiovascular risk if it's started early, but the evidence for using MHT in pre-existing cardiovascular disease or those with significant cardiovascular risk factors, for example, uncontrolled hypertension or high cholesterol, it is conflicting. in general, it's thought to be high risk, but there isn't actually any definitive evidence of harm. Baseline cardiovascular risk is really important, and having that conversation with women about the risk-benefit balance is key. The British Menopause Society has really good guidelines about individual cardiovascular conditions, including things like starting MHT after myocardial infarction, so it's not a definite no-no. We know that the menopause is associated with negative metabolic changes, but whether or not MHT can improve these is unclear. In hypertension, we know that MHT can sometimes cause an idiosyncratic rise in blood pressure, but this is temporary. And in women with well-controlled hypertension on hypertensives, it's safe to start MHT just with a bit of increased blood pressure monitoring. Similarly, there is some evidence that estrogen can improve insulin resistance. So although diabetes isn't a contraindication, MHT, we have to offset that with the fact that diabetes is a pro-arthrogenic and pro-thrombotic disease, and we need to sort of think about that as well. There is emerging evidence that transdermal estrogen perhaps has a more neutral or even favourable effect on cardiovascular profile, and we know that the type of MHT preparation can help. So, for example, body-identical progesterones or micronized progesterones are lower risk than, for example, medroxyprogesterone acetate. So we know that oral MHT can increase the risk of venous thromboembolism. There is a risk ratio of 2 found in some randomized control trials. Actually, a systematic review in 2022 confirmed that transdermal estrogen does not increase the risk. So people with risk factors, including obesity, which is a common risk factor, can be offered transdermal estrogen, and we would just tend to avoid it for current VTEs, unprovoked previous VTEs, or thrombophilias. And if we look at this slide, I've just taken an extract from the National Institute for Health and Care Excellence from the UK, and there's not actually that many absolute contraindications to MHT, and often transdermal estrogen can sort of offset some of these adverse effects. So we can definitely start MHT in women with risk factors or existing disease, but we just have to take an individualized approach and sort of balance risk and benefits. MHT can increase the risk of cancer. So a little bit of history. MHT actually came about in the 60s, and it was used heavily in the UK until the 90s. And prescriptions literally halved overnight because of the publication of some studies that showed that it significantly increased the risk of stroke and breast cancer. But actually these studies, the Women's Health Initiative and the Million Women study, were similar. They had significant limitations in their methodology. But after 20 years, the aftermath of these still remain, and people still remain suspicious. Your baseline risk of breast cancer really varies according to underlying risk factors. And yes, combination MHT can increase the risk of breast cancer, but it is small, and it's related to the duration and reduces after cessation. And there's no actual evidence of any mortality associated with this increased risk of breast cancer. And what I find really useful to discuss with my patients is putting this risk into perspective. So yes, it does increase the risk slightly, but actually, if you are obese or you have a body mass index over sort of 30, 35, then your risk is massively increased, as is if you excessively drink alcohol. So we discussed that unopposed estrogen in women with a uterus can significantly increase the risk of endometrial cancer, which has been established for a long time. But actually, if you are on combined MHT and you're using the progesterone correctly, it doesn't increase the risk of endometrial hyperplasia or endometrial cancer. In terms of ovarian cancer, there was a meta-analysis with 52 epidemiological studies of women at around 50, and they found that it basically adds an additional case per 1,000 women over 5 years. And in terms of colorectal cancer, we think there's actually a reduced risk according if you use MHT. So yes, there's a small risk, and we need to tell our women about this, but we need to put it into perspective and talk about other lifestyle risk reduction strategies as well. MHT is an important consideration in women living with HIV. So there's not a huge amount of evidence out there, but from what we do know, women living with HIV have high levels of menopause symptoms. And what this means is then they have less adherence to their antiretroviral medication, and they have poor engagement with HIV care. And what often happens is because of the breadth of menopause symptoms that we talked about at the start, combine this with HIV, particularly HIV that isn't well controlled, it can make the diagnosis of menopause really difficult, and it often goes entirely missed. We know that HIV is associated with an increased risk of cardiovascular disease and osteoporosis, and in principle, the health benefits of MHT can help women with HIV just the same as women without living with HIV. We would prefer to use the transdermal route because of lower thromboembolic events and gastrointestinal side effects, but actually, in terms of interactions, they're possible between MHT and certain antivirals, but it's important to know that they do not affect the antivirals themselves. The antivirals change the estrogen and progesterone levels in MHT, so it means that we need to adjust the doses of the MHT to make sure that they're having an effect and causing symptomatic relief. But we don't have to worry about suboptimal treatment of HIV because it's not the antiretrovirals that are affected. So yes, it is an important consideration. Depending on the control of the HIV, understandably, it may not be your top priority, but it's important to consider menopause and differentials when women are reaching that time of their life. So I have gone through everything very quickly there, but I just wanted to leave you on this last bit of food for thought. In the UK in the 1920s, the average life expectancy for a woman was 59, and it is now 81. Women are spending much longer in the menopause, and it requires us as healthcare professionals and the general public to change the way we view menopause. It's no longer the end of life, it's the start of a new stage of life when women are still active and they're often still working. So a woman should be able to choose whether she thinks she needs MHT to live her life to the full potential and not be burdened by the symptoms of menopause and the possible effects of lowering estrogen. It obviously depends on what's available in terms of your resources, but it's not something that should be forgotten. So in summary, menopause can have a profound effect on women, and it can affect different women from different backgrounds differently. MHT can help not only relieve symptoms, but provide long-term health benefits, particularly when started early. For most women, the benefits of MHT outweigh the risks, and it's our job as healthcare professionals to help women access these. In those with underlying health conditions or risk factors, we have to balance the pros and cons of MHT and not rule it out completely, and always think about transdermal routes being safer. Thank you so much for your time.
Thank you. And having said that, we have concluded the scientific session. We have concluded all the 9 presentations that were listed for this scientific exchange. And now, on behalf of Merck Foundation, I would like to conclude this wonderful session with a vote of thanks to all our esteemed speakers and attendees for joining us today and making this knowledge-sharing session a huge success. We hope that the global health situation stabilizes soon and look forward to meeting you all in person again for more learning and networking opportunities in the future. Please be reminded to visit our website, merckfoundation.com, and download the Merck Foundation app from the Play Store or the App Store to stay updated about the various courses available and path-breaking initiatives undertaken by Merck Foundation. Thank you, and please be safe.